Welcome to this video entitled Cellular Adaptations, Cell Injury, and Cell Death. Cellular pathology is the study of how cells respond to stress, injury, and disease. Every disease process begins with changes inside cells. Understanding these changes helps pharmacists connect symptoms, lab results, and treatment choices. Cells are constantly adapting to survive. When stress is mild, cells adjust their structure or function. This process is called cellular adaptation. Hypertrophy happens when cells increase in size, like enlarged heart muscle in hypertension. Hyperplasia occurs when the number of cells increases, such as tissue growth during healing. Atrophy is the shrinking of cells due to reduced workload or poor nutrition. Metaplasia occurs when one mature cell type changes into another, often as protection against chronic irritation. But adaptation has limits. When stress becomes severe or prolonged, cell injury begins. One major cause is the formation of reactive oxygen species, or ROS. These unstable molecules damage proteins, lipids, and DNA. Oxidative stress caused by reactive oxygen species is linked to aging, inflammation, cancer, and drug toxicity. Another important mechanism is ATP depletion. ATP is the cell's energy source. Without enough ATP, cells cannot maintain normal function. Ion pumps fail, sodium and water enter the cell, and swelling occurs. If energy loss continues, the cell may die. Cell death mainly occurs through necrosis or apoptosis. Necrosis is uncontrolled cell death caused by severe injury. The cell swells, bursts, and triggers inflammation in surrounding tissue. This often happens in burns, infections, or heart attacks. Necrosis is usually harmful and chaotic. Apoptosis, on the other hand, is programmed cell death. It is controlled and organized. The cell shrinks, breaks into small fragments, and is removed without inflammation. Apoptosis is essential for normal growth, immune regulation, and removal of damaged cells. It can also be triggered by chemotherapy or DNA damage. Understanding the difference between necrosis and apoptosis is important in pharmacy practice, because many diseases and medications influence these pathways differently. Clinical biomarkers help healthcare professionals detect cellular injury and monitor disease progression. Troponins are released during heart muscle damage and are key markers for myocardial infarction. Liver enzymes such as ALT and AST indicate hepatocellular injury. Creatinine levels reflect kidney function, while C-reactive protein signals inflammation. Pharmacists use these biomarkers to assess drug safety, monitor therapy, and support clinical decisions. Cellular pathology connects microscopic cell changes to real clinical outcomes. By understanding how cells adapt, become injured, and die, pharmacy professionals can better understand disease mechanisms and improve patient care. Cells are constantly working to stay healthy and balanced. This healthy balance is called homeostasis. Think of it as the cell's normal steady state, where everything is running smoothly. Nutrients are moving in, waste is moving out, and the cell is carrying out its functions without trouble. This is the ideal condition for survival. But cells do not always live in perfect conditions. They are constantly exposed to stress. Stress can be physiological, like exercise or temporary changes in oxygen demand. It can also be pathological, such as infection, toxins, reduced blood flow, or physical injury. Stress challenges the cell and forces it to respond. When stress appears, cells try to adapt. Adaptation is the cell's survival strategy. It involves structural or functional changes that help the cell cope with new demands. Sometimes a cell becomes larger to handle extra workload. Sometimes it reduces activity to conserve energy. Other times, it changes its metabolism to survive in difficult conditions. These adjustments are designed to maintain viability and restore balance. Adaptation is usually very effective, but only up to a point. Every cell has limits. If the stress becomes too intense, lasts too long, or occurs too suddenly, the cell can no longer keep up. This is when cell injury begins. Cell injury happens when the stress exceeds the cell's adaptive capacity. At this stage, the cell's normal processes start to fail. Energy production may decrease. Membranes may become damaged. Waste products can build up, and important cellular structures may stop working properly. If the cause of injury is removed quickly, the cell may recover. This is called reversible injury. However, if the damage continues, the injury becomes irreversible. The cell reaches a point where recovery is no longer possible. This leads to cell death. There are two major ways cells die. The first is necrosis. Necrosis is uncontrolled cell death caused by severe injury. The cell swells, bursts, and releases its contents, often triggering inflammation in surrounding tissues. The second is apoptosis. This is programmed cell death, a carefully controlled process where the cell essentially shuts itself down in an organized way. Apoptosis is important for normal growth, development, and removing damaged cells without causing inflammation. So the journey of a cell follows a clear continuum. It begins with homeostasis, moves through stress and adaptation, progresses to injury when limits are exceeded, and ends in death if recovery is impossible. Understanding this continuum helps explain how diseases begin and how the body responds to damage. When we study disease, two important ideas help us understand what is happening. These are etiology and pathogenesis. They sound similar, but they answer very different questions. Etiology is the why of disease. It explains the underlying cause or reason a disease happens in the first place. Think of it as the starting point. A disease can be caused by bacteria, viruses, toxins, genetic mutations, poor nutrition, immune system problems, or environmental exposures. For example, if a patient has tuberculosis, the etiology is infection by Mycobacterium tuberculosis. If someone has sickle cell disease, the etiology is a genetic mutation. Etiology tells us what triggered the problem. Pathogenesis is the how of disease. It describes the chain of events that happens after the cause is introduced. It explains the biochemical, cellular, and molecular mechanisms that lead to signs and symptoms. This is the process of disease development. For example, in a bacterial infection, the etiology is the invading bacteria. The pathogenesis is what the bacteria do inside the body. They may release toxins, trigger inflammation, damage tissues, and activate immune responses. These steps produce symptoms like fever, pain, and swelling. Think of it this way. If etiology is the spark that starts a fire, pathogenesis is how the fire spreads and causes damage. This difference is very important in pharmacy and medicine. Pharmacists often use this understanding to guide treatment decisions. Sometimes treatment targets pathogenesis. This means controlling the harmful processes happening in the body. For example, anti-inflammatory drugs reduce inflammation. Pain relievers block pain pathways. Antihypertensive drugs lower blood pressure by altering biological mechanisms. These treatments manage symptoms and reduce damage, but they may not remove the original cause. Other times, treatment targets etiology. This means removing or eliminating the root cause of disease. Antibiotics kill bacteria. Antidotes neutralize toxins. Certain therapies correct hormonal deficiencies. These treatments aim to cure the disease by addressing its source. In many cases, both approaches are needed. A patient with bacterial pneumonia may need antibiotics to eliminate the bacteria and fever-reducing medicine to control symptoms while healing occurs. This is why pharmacists must understand both etiology and pathogenesis. Knowing the cause helps identify the right cure. Understanding the mechanism helps manage symptoms and prevent complications. So remember it simply. Etiology is why disease starts. Pathogenesis is how disease develops. Together, they form the foundation of rational drug therapy and smarter patient care. Pharmacists play a vital role in protecting cell health and preventing disease before serious damage happens. Their work goes far beyond simply dispensing medicines. Pharmacists are trained to recognize early warning signs that cells are under stress and to help prevent that stress from becoming permanent injury. One important role is identifying early cellular stress signals. Cells often show distress before a patient develops severe symptoms. These warning signs may appear as abnormal laboratory results, changes in vital signs, unusual fatigue, mild organ dysfunction, or subtle biochemical changes. Pharmacists review these clues carefully. By spotting early problems, they can recommend action before major tissue damage occurs. Another critical responsibility is preventing drug-induced cellular injury. While medicines are designed to heal, some can also harm cells if not used correctly. This is especially true for the liver and kidneys, which process and eliminate many drugs. Drug-induced liver injury, often called DILI, happens when medications damage liver cells. This can lead to inflammation, reduced liver function, or even liver failure if unnoticed. Certain antibiotics, anticonvulsants, and pain medications can increase this risk. Nephrotoxicity is another major concern. This happens when drugs injure kidney cells, reducing the kidney's ability to filter waste and maintain balance. Some antibiotics, chemotherapy drugs, and anti-inflammatory medicines are known causes. Pharmacists help prevent these problems by reviewing doses, checking drug interactions, adjusting therapy for high-risk patients, and recommending safer alternatives when needed. Therapeutic drug monitoring, or TDM, is another key area where pharmacists protect cellular health. Some medicines work within a narrow concentration range. Too little may fail to treat disease. Too much can damage cells and organs. Pharmacists use blood level monitoring to ensure drug concentrations stay within the safe and effective range. They interpret results, adjust dosing schedules, and work with the healthcare team to personalize treatment. This improves outcomes while reducing toxicity. Patient counseling is also essential. Lifestyle choices directly affect how well cells function and recover. Poor nutrition, smoking, alcohol misuse, dehydration, stress, and lack of sleep can weaken cellular defenses and increase drug toxicity. Pharmacists educate patients on healthy habits that support cellular repair and resilience. They may advise proper hydration to protect the kidneys, balanced nutrition to support metabolism, limiting alcohol to reduce liver strain, and adherence to prescribed therapy to avoid complications. At its core, the pharmacist's role is prevention, protection, and optimization. By identifying early stress, preventing medication-related injury, monitoring therapy carefully, and promoting healthy lifestyles, pharmacists help keep cells functioning at their best. Healthy cells mean healthier organs. Healthier organs mean healthier patients. That is why pharmacists are essential guardians of cellular health. Cells are constantly adjusting to survive changing conditions. This ability is called adaptation. Adaptation is the process by which cells make reversible structural or functional changes in response to stress or changing demands. The word reversible is very important here. It means the cell has not been permanently damaged. Instead, it is making temporary adjustments to help itself cope. If normal conditions return, the cell can often go back to its original healthy state. Adaptation is a survival strategy. Cells are always trying to maintain balance and stay alive. When their environment changes, they respond by modifying how they work or even how they look. These changes help the cell continue functioning despite stress. The main goal of adaptation is to achieve a new steady state. This means the cell finds a new level of balance that allows it to survive under different conditions. It may not be exactly the same as its original state, but it is stable enough to preserve viability and keep essential processes going. For example, if a muscle is exercised regularly, its cells adapt by becoming larger and stronger. This helps the muscle handle increased workload more efficiently. If oxygen levels drop for a period of time, some cells may adjust their metabolism to use available oxygen more effectively. These changes support survival. Adaptation can happen in two main ways. It can be physiologic or pathologic. Physiologic adaptation happens in response to normal, healthy stimuli. These are expected adjustments that help the body function better. For example, muscle growth after exercise is a physiologic adaptation. During pregnancy, the uterus enlarges to support the growing baby. These are normal responses that improve function. Pathologic adaptation happens when cells respond to excessive or harmful stress. This could include high blood pressure, chronic inflammation, toxin exposure, or nutrient deprivation. The cell adapts to protect itself, but these changes are often signs that something is wrong. For example, if the heart has to pump against high blood pressure for a long time, heart muscle cells may enlarge to manage the extra workload. This helps at first, but if the stress continues, the adaptation can eventually become harmful and lead to injury. That is why adaptation is both protective and limited. It helps cells survive difficult conditions, but only up to a point. If the stress becomes too severe or lasts too long, adaptation may fail. When that happens, the cell moves from adaptation to injury. Understanding adaptation helps us understand how disease develops and how the body tries to defend itself. It shows that cells are not passive structures. They are active, responsive, and constantly working to preserve life. Adaptation is one of the most important ways they do that. Hypertrophy is one of the most common ways cells adapt to increased demand. It happens when cells increase in size, causing the affected organ or tissue to become larger. The key idea is simple. In hypertrophy, the number of cells does not increase. No new cells are created. Instead, the existing cells grow bigger. This happens because some cells cannot divide easily. Cells like cardiac muscle cells have a limited ability to multiply. So when they face extra workload, they respond by increasing their size instead of making new cells. As cells enlarge, they produce more structural proteins and functional components. This gives them greater strength and capacity to handle stress. It is the cell's way of adapting to increased demands while maintaining function. Hypertrophy can be physiologic, which means it happens as a normal and healthy response. A great example is skeletal muscle growth during exercise. When you lift weights or do resistance training, muscle fibers experience increased workload. In response, the muscle cells enlarge. They produce more contractile proteins, which makes the muscle stronger and bigger over time. This is a beneficial adaptation. It improves performance and helps the body meet physical demands more efficiently. Hypertrophy can also happen in normal life situations. For example, the uterus enlarges during pregnancy because its muscle cells increase in size to support the growing fetus. This is another healthy, physiologic adaptation. But hypertrophy is not always beneficial. It can also be pathologic, meaning it develops in response to harmful or excessive stress. A classic example is left ventricular hypertrophy caused by high blood pressure. The left ventricle is the part of the heart that pumps blood to the body. When blood pressure is consistently high, the heart has to work harder to push blood forward. To manage this extra workload, the heart muscle cells enlarge. The wall of the left ventricle becomes thicker and stronger at first. This helps the heart keep pumping effectively. But over time, this adaptation can become harmful. The enlarged heart muscle needs more oxygen and becomes less flexible. This can reduce efficiency, impair filling of the heart, and eventually lead to heart failure if the stress continues. This shows an important principle of cell adaptation. What begins as a protective response can become damaging if the underlying stress is not corrected. Hypertrophy is the cell's way of saying, "I need to work harder, so I must become stronger." It is a remarkable survival strategy. When controlled and temporary, it helps the body perform better. When excessive and prolonged, it can contribute to disease. Understanding hypertrophy helps us see how cells respond to challenge, and why managing long-term stress on the body is so important for health. Hypertrophy does not happen by chance. It is a carefully controlled cellular response to increased workload or stress. When a cell is asked to do more work, it activates internal systems that help it grow larger and stronger. The process begins when the cell senses increased demand. This demand could come from exercise, hormonal stimulation, or pressure overload, like high blood pressure forcing the heart to pump harder. The cell detects these changes through special receptors and signaling molecules. These signals tell the cell that it must adapt to survive and keep functioning effectively. Once the signal is received, certain genes inside the nucleus are activated. This is a key step in hypertrophy. Gene activation changes the cell's instructions for protein production. The cell begins making more proteins needed for structure and function. These proteins help increase the cell's capacity to perform work. This leads to enhanced protein synthesis. Protein-building machinery inside the cell becomes more active. More structural proteins are produced, making the cell physically larger and stronger. In muscle cells, this often means producing more contractile proteins, which improve force generation. In other cells, it may involve producing proteins that support metabolism or stress resistance. As protein production increases, the cell also expands its internal machinery. Organelles grow in size and number to support the larger workload. Mitochondria often increase because the growing cell needs more energy. Since mitochondria produce ATP, adding more of them helps meet rising energy demands. In muscle cells, myofilaments also increase. These are the protein fibers responsible for contraction. More myofilaments mean greater strength and improved performance. Other structures, such as the endoplasmic reticulum and ribosomes, may also expand to support increased protein production and processing. This entire process is controlled by signaling pathways. Two of the most important are the PI3K-AKT pathway and G-protein-coupled receptor pathways. The PI3K-AKT pathway is often activated during physiologic hypertrophy, like muscle growth from exercise. It promotes healthy cell growth, protein synthesis, and survival. This pathway helps cells grow in a controlled and beneficial way. G-protein-coupled receptor signaling is commonly involved in pathologic hypertrophy, such as heart enlargement caused by chronic hypertension. It responds to hormones and stress signals that tell the cell to grow under pressure. At first, this helps the cell cope. But if overstimulated for too long, it can contribute to harmful remodeling and disease. So hypertrophy is really the result of cellular communication and adaptation. Increased demand activates genes. Genes increase protein production. Organelles expand. Signaling pathways guide the process. It is the cell's way of upgrading itself to handle greater challenges. This shows just how dynamic and intelligent cellular adaptation can be. Hyperplasia is another important way cells adapt to changing demands. Unlike hypertrophy, which makes cells larger, hyperplasia increases the number of cells. This means the tissue or organ becomes bigger because more cells are being produced. The individual cells are usually normal in size, but there are simply more of them. Hyperplasia happens when cells are capable of dividing. These cells respond to signals that tell them to multiply. This allows the body to increase tissue mass when extra function or repair is needed. Hyperplasia is usually a controlled and organized process. It happens through activation of growth factors and cellular signaling pathways that stimulate cell division. There are different types of hyperplasia, and many are completely normal. One common type is hormonal hyperplasia. This happens when hormones stimulate cell growth to meet normal physiological needs. A good example is the female breast during puberty and pregnancy. Hormones such as estrogen and progesterone stimulate the glandular epithelial cells to multiply. This prepares the breast for future milk production. This increase in cell number is healthy and expected. It is part of normal development and reproductive function. Another important type is compensatory hyperplasia. This happens when the body replaces lost tissue after injury or surgery. The liver is the classic example. If part of the liver is surgically removed, the remaining liver cells begin dividing rapidly. This allows the liver to restore its original size and function. This is one of the most remarkable examples of the body's regenerative ability. The liver does not grow a brand new organ. Instead, the remaining cells multiply until normal tissue mass is restored. Hyperplasia can also become pathologic. This happens when excessive stimulation causes too much cell growth. Pathologic hyperplasia is often caused by excess hormones or abnormal growth factor signals. For example, repeated hormonal stimulation can cause endometrial hyperplasia, where the lining of the uterus becomes excessively thick. Another example is skin warts. These are caused by certain strains of human papillomavirus, or HPV. The virus stimulates skin cells to divide rapidly, creating raised growths on the skin. Even though pathologic hyperplasia is abnormal, it is still usually controlled. The cells respond to signals and stop dividing if the stimulation is removed. This is different from cancer, where cell growth becomes uncontrolled and independent of normal regulation. Hyperplasia shows how adaptable the body can be. It allows tissues to grow, repair, and respond to changing demands. When properly regulated, it supports health and healing. When overstimulated, it can contribute to disease. Understanding hyperplasia helps us see how cells balance growth with control, and why proper regulation is essential for normal body function. Atrophy is a process where cells shrink and, in some cases, decrease in number. This causes a tissue or organ to become smaller and less active over time. It is the body's way of adapting to reduced demand or limited resources. Instead of maintaining full size and activity, cells scale back to conserve energy and survive under less favorable conditions. Atrophy is often a protective response. The cell reduces its workload and lowers its metabolic activity to match what is available. This process usually involves decreased protein synthesis and increased breakdown of cellular components. As the cell loses structural proteins and organelles, it becomes smaller and less efficient. In some tissues, prolonged stress can also lead to cell loss, which further reduces organ size. There are several common causes of atrophy. One major cause is reduced workload, also called disuse atrophy. This happens when a muscle is not being used regularly. For example, if a limb is placed in a cast for several weeks, the muscles begin to shrink because they are not being stimulated to contract. The body recognizes that the full muscle mass is no longer needed, so it conserves resources by reducing cell size. Another important cause is loss of innervation. Muscles depend on nerve signals to remain active and healthy. If nerve supply is damaged, the muscle no longer receives the stimulation it needs. Without these signals, muscle cells begin to shrink and weaken. Over time, severe muscle wasting can occur. Diminished blood supply is another cause of atrophy. Cells need oxygen and nutrients to maintain normal structure and function. If blood flow is reduced, cells receive less support. To survive, they decrease their activity and shrink. This is often seen in aging tissues or organs affected by narrowed blood vessels. Malnutrition can also cause atrophy. When the body does not receive enough nutrients, it cannot maintain normal cell growth and repair. To preserve energy for vital organs, the body breaks down proteins in less essential tissues like skeletal muscle. This causes visible wasting and weakness. No matter the cause, atrophy leads to reduced organ volume and reduced function. A smaller muscle produces less strength. An atrophied brain region may lose processing ability. A shrunken gland may produce fewer hormones or enzymes. If the underlying cause is corrected early, atrophy can sometimes be reversed. Exercise can rebuild disused muscle. Improved nutrition can restore tissue mass. Restoring blood flow may improve function. But if atrophy becomes severe or prolonged, recovery may be limited. Atrophy reminds us that cells are highly responsive to their environment. When stimulation decreases or resources become scarce, cells adapt by doing less. It is a survival strategy, but one that comes with reduced performance and function. Understanding atrophy helps explain why movement, nutrition, and healthy circulation are so essential for long-term health. Atrophy happens through carefully controlled changes inside the cell. It is not simply a cell becoming smaller by accident. It is an active survival response designed to conserve energy when conditions are unfavorable. The process begins when the cell senses reduced demand or limited resources. This could happen because of inactivity, poor nutrition, reduced blood flow, or loss of nerve stimulation. When this happens, the cell shifts into energy-saving mode. It reduces activities that are no longer necessary and begins breaking down parts of itself to survive. One major mechanism is decreased protein synthesis. Under normal conditions, cells constantly build proteins to maintain structure and function. These proteins support muscle contraction, enzyme activity, repair, and overall cell stability. During atrophy, the signals that promote protein production become weaker. The cell slows down its protein-building machinery. As fewer proteins are made, the cell gradually loses mass. Structural components shrink, and the cell becomes smaller and less active. At the same time, protein breakdown increases. This happens mainly through the ubiquitin proteasome pathway, which is one of the cell's most important recycling systems. Here is how it works. Damaged or unneeded proteins are tagged with a small molecule called ubiquitin. Think of ubiquitin as a label that marks proteins for disposal. Once tagged, these proteins are sent to a structure called the proteasome. The proteasome acts like a molecular shredder. It breaks the proteins into smaller pieces that can be reused or removed. During atrophy, this pathway becomes highly active. The cell starts breaking down structural proteins faster than it replaces them. This causes loss of cell mass and contributes to shrinking of tissues like muscle. Another important mechanism is autophagy. Autophagy means self-eating. It is a process where the cell digests its own worn-out organelles and internal components. This may sound harmful, but it is actually a survival strategy. When nutrients are scarce, the cell breaks down non-essential parts to release energy and raw materials. Special structures surround damaged organelles and deliver them to lysosomes, where they are broken down and recycled. This helps the cell survive periods of stress or starvation. Autophagy also clears away defective components, keeping the cell cleaner and more efficient. But if autophagy becomes excessive or prolonged, too much cellular material is lost, and the cell becomes severely weakened. So the mechanism of atrophy involves a balance shift. The cell makes fewer proteins. It breaks down more proteins. It recycles internal structures through autophagy. Together, these changes reduce cell size and conserve resources. This is the cell's way of adapting to difficult conditions. It sacrifices growth and strength to preserve survival. Understanding these mechanisms helps explain why inactivity, starvation, and chronic disease can lead to tissue wasting, and why restoring activity and nutrition is so important for recovery. Metaplasia is a fascinating example of cellular adaptation. It happens when one mature cell type is replaced by another mature cell type that is better able to handle stress. This is a reversible change, which means it can often return to normal if the harmful stimulus is removed. Metaplasia is the body's way of protecting tissues that are exposed to chronic irritation or injury. Instead of allowing fragile cells to remain in a harsh environment, the body replaces them with tougher cells that can survive better under stress. This process usually happens through reprogramming of stem cells or immature cells. These cells receive signals that direct them to develop into a different type of mature cell. The result is a tissue that is better suited to withstand the damaging conditions. A classic example is found in the respiratory tract of smokers. Normally, the airways are lined with columnar epithelial cells. These cells are tall, delicate, and highly specialized. They contain cilia, which are tiny hair-like structures that help sweep mucus and trapped particles out of the lungs. They also support mucus secretion, which helps trap dust, bacteria, and harmful substances before they can reach deeper parts of the lungs. This system is essential for keeping the airways clean and protected. But cigarette smoke constantly irritates these cells. The toxins and heat create a harsh environment that delicate columnar cells struggle to tolerate. To adapt, the tissue gradually replaces these columnar cells with squamous epithelial cells. Squamous cells are flatter and tougher. They are more resistant to physical and chemical stress, making them better suited for survival in this toxic environment. At first, this seems like a smart protective response. The new cells can tolerate irritation more effectively and are less likely to be damaged. But this adaptation comes with a cost. Squamous cells do not have cilia. They also do not support normal mucus secretion the way columnar cells do. This means the airway loses important cleaning and protective functions. Without proper mucus clearance, harmful particles and microbes can accumulate. This increases the risk of infection, inflammation, and long-term lung damage. If smoking stops early enough, the metaplasia may reverse, and normal columnar cells can return. But if the irritation continues for many years, metaplasia can progress to more serious changes, including dysplasia, where cells become abnormal and disorganized. Dysplasia can increase the risk of cancer. So metaplasia is both protective and potentially dangerous. It helps cells survive a hostile environment, but it often sacrifices specialized function. It is the cell's way of choosing survival over efficiency. Understanding metaplasia helps explain how chronic irritation can reshape tissues and why removing harmful triggers is so important for long-term health. Metaplasia is a protective adaptation, but it is not without risks. While it helps cells survive in a harsh environment, it often comes at a cost. The biggest immediate risk is loss of normal function. When one mature cell type is replaced by another, the new cells may be stronger and more resistant to stress, but they usually cannot perform all the specialized tasks of the original cells. This means the tissue may survive, but it often works less effectively. A good example is metaplasia in the lungs of a smoker. Normally, the respiratory tract is lined with columnar epithelial cells that have tiny hair-like structures called cilia. These cilia constantly move mucus upward and out of the airways. This process is called ciliary clearance. It helps trap and remove dust, bacteria, toxins, and other harmful particles before they can damage the lungs. These cells also support mucus production, which acts like a sticky defense barrier. Together, mucus and cilia form an important cleaning system that protects the respiratory tract. When cigarette smoke causes chronic irritation, these delicate columnar cells are often replaced by tougher squamous cells. Squamous cells can tolerate smoke better, but they do not have cilia. They also do not support mucus clearance in the same way. As a result, the lung loses one of its most important defense mechanisms. Without effective ciliary clearance, mucus and harmful particles build up. This increases the risk of infection, chronic inflammation, persistent cough, and long-term lung damage. So while metaplasia improves survival under stress, it reduces efficiency and weakens normal tissue protection. The second and more serious risk happens if the harmful stimulus continues for a long time. Metaplasia itself is reversible, but chronic exposure to stress can push cells further down a dangerous path. Over time, persistent irritation can lead to dysplasia. Dysplasia is when cells begin to grow abnormally and lose their normal organization. They may become irregular in size, shape, and arrangement. This is no longer just adaptation. It is a warning sign of potential precancerous change. If the damaging stimulus continues, dysplastic cells can accumulate genetic mutations. These mutations can disrupt normal growth control. Eventually, this may lead to malignant transformation, which means the cells become cancerous. This is why long-term smoking significantly increases the risk of lung cancer. The process often begins with metaplasia, progresses to dysplasia, and may eventually develop into invasive cancer if the trigger is not removed. Metaplasia shows how the body tries to protect itself under pressure, but it also reminds us that adaptation has limits. When harmful stress continues for too long, protective changes can become dangerous. That is why early intervention matters. Removing the harmful stimulus can allow tissues to recover and greatly reduce the risk of cancer and permanent damage. Dysplasia is a disorder of cell growth and maturation. It mainly affects epithelial tissues, like the skin or lining of organs. In dysplasia, cells start losing their normal appearance. They become irregular in size, shape, and arrangement. Some cells may look larger than normal. Others may appear darker or more crowded together. The tissue begins to look disorganized under the microscope. Normal structure and uniformity are gradually lost. Unlike healthy adaptation, dysplasia is not considered a true adaptive change. It is often viewed as a warning sign before cancer develops. That is why dysplasia is called a pre-cancerous condition. It does not mean cancer is already present, but it shows that the cells are moving in an abnormal direction. Persistent irritation and chronic inflammation can trigger dysplasia. Smoking, infections, and long-term chemical exposure are common causes. For example, cervical dysplasia may occur after persistent HPV infection. In smokers, dysplasia can develop in the respiratory tract lining. One important feature of dysplasia is reversibility. If the harmful stimulus is removed early, the tissue may return to normal. But if the abnormal changes continue, dysplasia can progress further. Mild dysplasia may become moderate or severe over time. Severe dysplasia has a much higher risk of turning into cancer. At this stage, the abnormal cells occupy most of the tissue thickness. This is why early detection is very important. Screening tests can identify dysplastic changes before cancer develops. A major difference exists between dysplasia and normal cellular adaptations. Adaptations are controlled, regulated, and usually protective. For instance, hypertrophy or hyperplasia helps cells survive stress. These changes are generally reversible and organized. Dysplasia, however, involves disordered and uncontrolled growth patterns. The cells lose their normal regulation and maturity. In simple terms, dysplasia is the body's cellular red flag. It signals that tissue growth is no longer completely normal. Recognizing dysplasia early can prevent progression to invasive cancer. That is why understanding these abnormal cellular changes is so important. Pause the video and carefully scrutinize the table before progressing to the next slide. Cardiac hypertrophy is the enlargement of the heart muscle. It commonly develops when the heart is forced to work harder than normal. One major trigger is chronic high blood pressure, also called hypertension. In hypertension, the heart must pump against increased resistance every day. Imagine trying to push open a heavy door repeatedly. Over time, your muscles become larger and stronger. The heart responds in a very similar way. The main cells involved are called cardiac myocytes. These cells cannot divide easily like many other body cells. Instead of increasing in number, they increase in size. To handle the extra workload, myocytes boost protein synthesis. They produce more structural proteins and contractile fibers. This allows the heart muscle to generate stronger contractions. As the cells enlarge, the ventricular walls become thicker. This process is especially common in the left ventricle. The left ventricle is responsible for pumping blood throughout the body. At first, cardiac hypertrophy can be beneficial. It helps the heart maintain adequate blood circulation. The thicker muscle works harder to overcome the high pressure. But this adaptation has limits. A larger muscle also demands more oxygen and nutrients. Here is where problems begin to appear. The blood vessels may not grow enough to supply the enlarged heart muscle. As a result, some areas receive inadequate oxygen. Over time, the heart becomes stiff and less efficient. The thickened walls may not relax properly between beats. This reduces the amount of blood filling the heart chambers. Patients may start experiencing fatigue and shortness of breath. Chest pain and reduced exercise tolerance can also develop. If hypertension continues untreated, the heart eventually weakens. The overworked muscle begins to fail. This condition is known as heart failure. In heart failure, the heart can no longer pump blood effectively. Fluid may build up in the lungs, legs, or other tissues. Cardiac hypertrophy shows how adaptation can become harmful over time. What begins as a protective response may later lead to serious disease. That is why controlling blood pressure is so important. Healthy eating, exercise, and medication can reduce the workload on the heart. Early treatment helps prevent long-term damage. It also lowers the risk of heart failure, stroke, and other complications. In simple terms, cardiac hypertrophy is the heart's attempt to survive stress. But without proper control of hypertension, the heart may eventually become exhausted. Barrett's esophagus is a classic example of metaplasia. It occurs when the lining of the esophagus changes because of chronic irritation. The most common cause is long-term acid reflux, also known as GERD. GERD stands for gastroesophageal reflux disease. Normally, stomach acid should stay inside the stomach. But in gastroesophageal reflux disease, acid repeatedly flows back into the esophagus. This constant acid exposure irritates and injures the esophageal lining. Patients often experience heartburn, chest discomfort, or a sour taste in the mouth. The normal esophagus is lined by squamous epithelium. These flat cells are designed to handle friction from swallowed food. But they are not very resistant to strong stomach acid. To protect itself, the body tries to adapt. Over time, the squamous cells are replaced by columnar epithelial cells. These new cells resemble the intestinal lining. They are better able to tolerate acidic conditions. This process is called metaplasia. One mature cell type changes into another mature cell type. In Barrett's esophagus, the tissue is essentially reprogrammed for survival. It is the body's attempt to reduce ongoing acid damage. At first, this adaptation may seem beneficial. The new lining is tougher against acid irritation. Symptoms may even become less severe in some people. But there is an important downside. Metaplastic cells carry a higher risk of becoming abnormal over time. Barrett's esophagus is considered a strong clinical marker for esophageal cancer risk. Specifically, it increases the risk of esophageal adenocarcinoma. This does not mean every patient with Barrett's esophagus will develop cancer. But the risk is significantly higher compared to the general population. Doctors often monitor these patients closely with endoscopy and biopsies. This helps detect early precancerous changes before cancer develops. Lifestyle changes can also help reduce damage. Weight control, avoiding smoking, and limiting alcohol are important steps. Patients are often advised to avoid late-night meals and spicy foods. Medications that reduce stomach acid are commonly prescribed as well. Barrett's esophagus is a powerful example of how the body adapts to stress. The cells change form in order to survive a harsh environment. However, adaptation sometimes comes with long-term consequences. What begins as protection can later increase cancer risk. That is why chronic acid reflux should never be ignored. Persistent heartburn may be more serious than many people realize. Endometrial hyperplasia is the abnormal thickening of the uterine lining. The uterine lining is also called the endometrium. This condition usually happens because of excess estrogen stimulation. Estrogen is a hormone that normally helps the endometrium grow during the menstrual cycle. Under normal conditions, estrogen and progesterone work together in balance. Estrogen stimulates growth, while progesterone controls and stabilizes that growth. Problems begin when estrogen acts without enough progesterone to balance it. This is called unopposed estrogen stimulation. As a result, the endometrial cells continue multiplying excessively. The lining becomes thicker and more crowded than normal. This overgrowth is known as hyperplasia. It is essentially an increase in the number of cells within the tissue. Several conditions can increase estrogen exposure. Obesity is one common cause because body fat can produce estrogen. Polycystic ovary syndrome, or PCOS, may also contribute. In some women, hormone replacement therapy can play a role as well. Menopause can also increase risk in certain situations. Ovulation may become irregular, leading to hormonal imbalance. One major symptom of endometrial hyperplasia is abnormal uterine bleeding. Periods may become unusually heavy, prolonged, or irregular. Some women experience bleeding between menstrual cycles. Postmenopausal bleeding is especially concerning and should never be ignored. The thickened lining becomes unstable and fragile. This makes bleeding more likely to occur. There are different types of endometrial hyperplasia. Some forms are relatively mild and reversible. Others contain abnormal cells known as atypia. Atypical hyperplasia is more serious. It carries a much higher risk of developing into endometrial carcinoma. Endometrial carcinoma is a cancer of the uterine lining. This is why early diagnosis is very important. Doctors may use ultrasound to evaluate the thickness of the endometrium. A biopsy is often performed to examine the cells more closely. Treatment depends on the severity of the condition. Hormonal therapy with progesterone may help reverse some cases. In more severe cases, surgery may be required. This is especially true if cancer risk becomes very high. Lifestyle changes can also reduce risk factors. Weight management and proper hormonal control are very important. Endometrial hyperplasia shows how hormones strongly influence tissue growth. When hormonal balance is lost, excessive cell growth can occur. It also reminds us that abnormal bleeding is never something to ignore. Sometimes it is the body's early warning sign of a more serious condition. Brain atrophy refers to the shrinking or loss of brain tissue. It occurs when neurons and their connections gradually disappear over time. Some degree of brain atrophy can happen during normal aging. As people grow older, certain brain cells naturally decrease in number. However, brain atrophy becomes much more severe in neurodegenerative diseases. One major example is Alzheimer's disease. In these conditions, brain cells are progressively damaged and destroyed. The communication pathways between neurons also begin to break down. The brain has folds and grooves on its surface. The raised folds are called gyri. The grooves between them are called sulci. In brain atrophy, the gyri become narrower and thinner. At the same time, the sulci become wider and more prominent. These structural changes are often visible on brain imaging scans. Doctors may detect them using CT scans or MRI studies. The shrinking happens because neurons are being lost. Synaptic connections between nerve cells also decrease significantly. Synapses are extremely important for communication in the brain. They allow neurons to send signals and process information rapidly. When these connections disappear, brain function becomes less efficient. Memory, thinking, and problem-solving abilities may begin to decline. Patients may struggle with concentration and learning new information. Simple daily activities can gradually become more difficult. In Alzheimer's disease, memory loss is often one of the earliest signs. People may forget names, conversations, or recent events. As the disease progresses, confusion and personality changes may develop. Language and decision-making skills can also be affected. Brain atrophy does not only affect memory. It may also influence movement, emotions, and behavior. Different diseases damage different parts of the brain. That is why symptoms can vary from one person to another. Several factors may contribute to accelerated brain atrophy. These include chronic alcohol use, stroke, traumatic brain injury, and infections. Poor blood supply to the brain can also worsen neuronal loss. Without enough oxygen and nutrients, neurons cannot survive properly. Although some age-related changes are expected, severe atrophy is not normal aging. It often signals underlying disease or long-term brain injury. Researchers continue studying ways to slow neurodegeneration. Healthy lifestyle habits may help protect brain function over time. Regular exercise, mental stimulation, good sleep, and balanced nutrition are important. Controlling blood pressure and diabetes mellitus may also reduce brain damage risk. Brain atrophy highlights how important neurons are for daily life. When brain cells and connections are lost, cognitive abilities gradually decline. This is why early recognition and treatment of neurological disease are so important. Skeletal muscle atrophy is the shrinking of muscle tissue. It happens when muscle fibers decrease in size and strength over time. This condition can occur naturally or because of disease. One common physiologic cause is aging. Age-related muscle loss is called sarcopenia. As people grow older, muscle mass gradually declines. Older adults may notice reduced strength and endurance. Simple tasks like climbing stairs may become more difficult. Physical activity also tends to decrease with age. This further contributes to muscle wasting and weakness. But muscle atrophy is not only linked to aging. It can also develop from pathologic conditions. One major cause is prolonged bed rest or immobility. This is known as disuse atrophy. Muscles need regular activity to maintain their size and function. When muscles are not used, the body begins breaking them down. For example, a patient confined to bed for weeks may lose significant muscle mass. Even astronauts in space experience muscle atrophy because of reduced gravity and movement. Another important cause is nerve damage. Muscles depend on nerve signals to stay active and healthy. If the nerve supply is interrupted, muscles stop receiving stimulation. Without these signals, muscle fibers gradually shrink and weaken. This is called denervation atrophy. It may occur after spinal cord injury, stroke, or nerve trauma. At the microscopic level, muscle proteins are actively broken down. The body increases protein degradation pathways during atrophy. One key molecule involved is MURF1. MURF1 stands for muscle ring finger 1. Muscle ring finger 1 is a type of ubiquitin lagase. Its job is to tag muscle proteins for destruction. Once tagged, these proteins are sent to the proteasome for breakdown. This process reduces muscle size and contributes to wasting. Increased muscle ring finger 1 activity is strongly associated with muscle atrophy. Scientists often study it when researching muscle loss diseases. As muscle tissue shrinks, strength and mobility decline. Patients may feel weak, tired, or unstable when walking. Severe muscle atrophy can reduce independence and quality of life. Falls and injuries also become more likely. Fortunately, some forms of muscle atrophy can improve. Exercise and physical therapy can help rebuild muscle strength. Resistance training is especially effective in stimulating muscle growth. Adequate nutrition and protein intake are also very important. Early movement after illness or surgery helps reduce disuse atrophy. Treating underlying nerve problems may also slow progression. Skeletal muscle atrophy shows how important activity is for muscle health. Muscles follow the principle of use it or lose it. When movement decreases or nerve supply is lost, muscles begin to shrink. But with proper intervention, some muscle function can often be restored. Cellular injury occurs when cells are exposed to harmful stress or damage. If the injury is mild, cells may recover and survive. But if the damage is severe, cells may die permanently. One major cause of cellular injury is hypoxia. Hypoxia means inadequate oxygen supply to tissues. Cells need oxygen to produce energy efficiently. Without enough oxygen, ATP production rapidly decreases. A common cause of hypoxia is ischemia. Ischemia happens when blood flow to tissues is reduced or blocked. For example, a blood clot in a coronary artery can reduce oxygen delivery to the heart. This may lead to a heart attack and tissue death. The brain is also highly sensitive to oxygen deprivation. Even a few minutes without oxygen can cause serious brain injury. Another important cause of cellular injury is toxins and drugs. Chemical substances can directly damage cell membranes and organelles. Some toxins come from the environment. Others may come from medications taken in excessive amounts. For example, alcohol can injure liver cells over time. Drug overdose may also cause severe tissue destruction. Heavy metals, pesticides, and industrial chemicals can damage multiple organs. These substances interfere with normal cellular metabolism and function. Infectious agents are another major cause of cellular injury. These include bacteria, viruses, fungi, and parasites. Bacteria may release toxins that destroy tissues directly. Viruses often invade cells and use them to reproduce. During viral infections, infected cells may burst or malfunction. This leads to inflammation and tissue damage. The immune system can also cause cellular injury. Normally, the immune system protects the body from harmful invaders. But sometimes it mistakenly attacks healthy tissues. This is known as autoimmunity. In autoimmune diseases, the body treats its own cells as foreign. The resulting inflammation can damage organs and tissues. For example, autoimmune reactions may affect joints, kidneys, skin, or the thyroid gland. Chronic inflammation gradually injures cells over time. Genetic abnormalities can also lead to cellular injury. Inherited mutations may produce defective proteins or enzymes. These abnormalities can interfere with normal cellular processes. Some genetic disorders cause toxic substances to accumulate inside cells. Nutritional imbalances are another important factor. Cells require vitamins, minerals, proteins, and energy to function properly. Malnutrition weakens cellular repair and defense mechanisms. Protein deficiency may impair tissue growth and healing. On the other hand, excessive nutrition can also cause damage. Obesity and high-fat diets may contribute to metabolic stress and inflammation. Cellular injury can result from many different causes. Sometimes several harmful factors act together at the same time. Understanding these causes helps explain how diseases develop in the body. It also highlights the importance of oxygen, nutrition, immunity, and healthy lifestyle choices in maintaining normal cell function. Hypoxia is one of the most common causes of cellular injury. It occurs when tissues do not receive enough oxygen to meet their needs. Oxygen is essential for normal cell survival. Cells use oxygen to produce energy in the form of ATP. Most ATP is generated inside mitochondria through oxidative phosphorylation. This process is highly dependent on a constant oxygen supply. When oxygen levels drop, energy production rapidly decreases. Cells begin to lose their ability to function normally. One major cause of hypoxia is ischemia. Ischemia means reduced blood flow to tissues. Blood carries oxygen and nutrients throughout the body. If blood flow is blocked, oxygen delivery falls immediately. For example, a clot in a coronary artery can reduce blood supply to the heart. This may cause ischemic injury and eventually a heart attack. The brain is also extremely sensitive to ischemia. Even a short interruption in blood flow can damage brain tissue. Another cause of hypoxia is inadequate oxygenation of blood. This often occurs in cardiorespiratory failure. In lung diseases, oxygen may not enter the bloodstream effectively. Conditions like pneumonia or severe asthma can reduce oxygen exchange. Heart failure can also impair oxygen delivery. If the heart cannot pump efficiently, tissues receive less oxygen-rich blood. Anemia is another important cause of hypoxia. In anemia, the blood has reduced oxygen carrying capacity. Hemoglobin inside red blood cells carries oxygen throughout the body. When hemoglobin levels fall, less oxygen reaches the tissues. Patients with anemia often feel weak and fatigued. Their cells are essentially functioning with limited oxygen supply. Hypoxia directly affects oxidative phosphorylation inside mitochondria. Without oxygen, ATP production declines dramatically. ATP is the main energy source for cellular activities. Cells need ATP to maintain membrane pumps, protein synthesis, and normal metabolism. When ATP levels drop, sodium and water accumulate inside the cell. This causes cellular swelling and dysfunction. Calcium balance is also disrupted during hypoxia. Excess calcium inside cells activates destructive enzymes. If oxygen deprivation continues, irreversible injury may occur. Cells may eventually die through necrosis or apoptosis. Different organs respond differently to hypoxia. The brain and heart are among the most vulnerable tissues. Muscles and skin can tolerate low oxygen slightly longer, but prolonged hypoxia damages almost every tissue in the body. Fortunately, early restoration of oxygen supply can reverse some injury. Rapid treatment is critical in ischemic and respiratory emergencies. Hypoxia demonstrates how dependent life is on oxygen. Without adequate oxygen, cells lose energy, function poorly, and may eventually die. That is why maintaining healthy circulation, lung function, and blood health is so important for overall survival. ATP depletion is one of the earliest and most important events in cellular injury. ATP is the main energy currency of the cell. Cells constantly need ATP to survive and function properly. Without enough ATP, essential cellular processes begin to fail. Most ATP is produced inside mitochondria through oxidative phosphorylation. This process depends heavily on oxygen supply. When oxygen levels fall, ATP production rapidly decreases. This commonly happens during hypoxia or ischemia. One major consequence is failure of the sodium-potassium pump. This pump is also called the Na+K+AT pump. Normally, the pump uses ATP to move sodium out of the cell. At the same time, it brings potassium into the cell. This helps maintain normal fluid and electrolyte balance. But when ATP is depleted, the pump stops working properly. Sodium begins accumulating inside the cell. Water follows sodium into the cell by osmosis. As water enters, the cell starts to swell. This swelling is known as cellular edema. The cell membrane may become stretched and fragile. Organelles like the endoplasmic reticulum and mitochondria also swell. At this stage, the injury may still be reversible. If oxygen and ATP are restored quickly, the cell can recover. Another important effect of ATP depletion is the switch to anaerobic glycolysis. Without enough oxygen, cells try producing energy without oxidative phosphorylation. Anaerobic glycolysis generates far less ATP than normal metabolism. It also produces lactic acid as a byproduct. Lactic acid begins accumulating inside the cell. As acid levels rise, intracellular pH falls. The lower pH interferes with many cellular enzymes and reactions. Proteins and structural components may begin malfunctioning. Chromatin inside the nucleus may also start clumping together. This is another sign of cellular stress and injury. ATP depletion also affects protein synthesis. Ribosomes detach from the rough endoplasmic reticulum. Ribosomes are essential for making proteins needed for cell survival. When they detach, protein production decreases significantly. Without adequate proteins, the cell cannot repair itself effectively. Membrane integrity and normal metabolism gradually worsen. If ATP depletion continues for too long, irreversible injury develops. The cell eventually loses the ability to recover. Membranes become severely damaged, and vital organelles fail completely. At this point, cell death may occur through necrosis or apoptosis. ATP depletion shows how dependent cells are on continuous energy supply. Even small interruptions in oxygen or blood flow can trigger major dysfunction. It also explains why organs like the heart and brain are highly vulnerable. These tissues require enormous amounts of ATP every second. In simple terms, ATP is the fuel that keeps cells alive. Without it, pumps fail, acids accumulate, proteins decline, and cells begin to break down. Mitochondria are often called the powerhouses of the cell. Their main job is to produce ATP, the cell's energy source. But mitochondria do much more than energy production. They also help regulate cell survival and cell death. When mitochondria become damaged, the entire cell is at risk. Mitochondrial injury is a major event in cellular damage and disease. Several harmful factors can injure mitochondria. One important factor is increased cytosolic calcium, also called Ca2+. Normally, calcium levels inside the cytoplasm are tightly controlled. But during cellular injury, calcium begins accumulating inside cells. Excess calcium enters mitochondria and disrupts their normal function. This interferes with ATP production and damages mitochondrial membranes. Reactive oxygen species, or ROS, are another major cause of injury. Reactive oxygen species are unstable molecules, sometimes called free radicals. They can attack proteins, lipids, and DNA inside the cell. Mitochondrial membranes are especially vulnerable to oxidative damage. Oxygen deprivation also harms mitochondria significantly. Without oxygen, oxidative phosphorylation cannot continue normally. ATP production drops, and the mitochondria begin to fail. The cell rapidly loses its energy supply. One critical consequence is opening of the mitochondrial permeability transition pore. This is often shortened to the MPT pore. The mitochondrial permeability transition pore forms in the mitochondrial membrane during severe stress. Once it opens, the membrane becomes abnormally permeable. Important molecules leak across the membrane uncontrollably. The mitochondria lose their ability to maintain normal function. ATP production collapses even further. Water also enters the mitochondria, causing swelling and dysfunction. If the damage becomes severe, proteins inside the mitochondria leak into the cytoplasm. One extremely important protein is cytochrome C. Normally, cytochrome C helps with energy production inside mitochondria, but when released into the cytosol, it sends a dangerous signal. Cytochrome C activates enzymes called caspases. These enzymes trigger apoptosis, also known as programmed cell death. Apoptosis is a controlled and organized form of cell death. The cell essentially activates its own self-destruction pathway. This process helps remove severely damaged cells safely. It prevents injured cells from harming surrounding tissues. Mitochondrial damage therefore plays a central role in many diseases. It is involved in heart disease, stroke, neurodegenerative disorders, and toxic injuries. For example, mitochondrial dysfunction is strongly linked to Alzheimer's disease and Parkinson's disease. Cells with high energy demands are especially vulnerable. The heart and brain depend heavily on healthy mitochondria. Even short periods of mitochondrial failure can cause major damage. In simple terms, mitochondria are both the cell's power generators and survival regulators. When they are damaged, energy production fails and cell death pathways are activated. That is why protecting mitochondrial function is essential for healthy cell survival. Calcium is one of the most tightly controlled substances inside the cell. Under normal conditions, the amount of calcium floating freely in the cytoplasm is extremely low. The cell works very hard to keep it that way. Most calcium is safely stored inside the endoplasmic reticulum and mitochondria. Very little is allowed to remain in the cytosol. That balance is critical for survival. But during cell injury, the membrane loses control. Suddenly, calcium starts rushing into the cell from the extracellular space. At the same time, stored calcium leaks out from the endoplasmic reticulum. This creates a dangerous calcium overload. And that overload becomes a major turning point in cell damage. Calcium itself is not always harmful. In fact, cells normally use calcium for signaling. It helps muscles contract. It helps nerves communicate. It helps enzymes switch on and off. But too much calcium becomes toxic. The cell's normal signaling system turns into a destructive process. Excess calcium activates proteases. Proteases begin breaking down structural proteins inside the cell. The cytoskeleton starts collapsing. The cell loses shape and stability. Calcium also activates ATPases. These enzymes rapidly consume ATP. The cell's energy stores become depleted. And without ATP, survival becomes difficult. Phospholipases are activated too. These enzymes attack membrane phospholipids. Cell membranes become weak and leaky. Mitochondrial membranes also get damaged. As membranes fail, the injury spreads even faster. More calcium enters the cell. More organelles stop functioning properly. Calcium also activates nucleases. These enzymes break apart DNA and RNA. Genetic material becomes fragmented. The nucleus begins to deteriorate. At this stage, the cell is in serious trouble. Energy production falls. Membranes rupture. Proteins are destroyed. DNA becomes damaged. Mitochondria are especially vulnerable. Excess calcium can trigger opening of mitochondrial permeability channels. This shuts down oxidative phosphorylation. ATP production drops dramatically. The mitochondria may also release proteins that trigger apoptosis. So calcium overload can push the cell toward programmed cell death. In severe injury, the damage becomes irreversible. The cell can no longer recover. Necrosis or apoptosis eventually follows. So even though calcium is essential for life, balance is everything. A small controlled amount supports normal function. But uncontrolled calcium influx can rapidly destroy the entire cell from within. Reactive oxygen species, or ROS, are highly reactive molecules produced during normal cellular metabolism. Every cell in the body generates small amounts of reactive oxygen species every day. This happens especially inside the mitochondria during ATP production. In controlled amounts, reactive oxygen species are actually useful. They help with cell signaling. They help immune cells destroy microbes. They even participate in normal physiological processes. But problems begin when reactive oxygen species production becomes excessive, or when the antioxidant defense systems become overwhelmed. This state is called oxidative stress. Many forms of injury can trigger excessive reactive oxygen species generation. Ionizing radiation is a classic example. Radiation splits water molecules and creates dangerous free radicals. Certain drugs and toxins can also increase reactive oxygen species formation. Some chemicals interfere with mitochondrial function. Others directly produce free radicals during metabolism. Inflammation is another major source. Activated neutrophils and macrophages intentionally generate reactive oxygen species to kill bacteria. But nearby healthy tissues can also get injured in the process. Reperfusion injury is especially important clinically. When blood supply returns after ischemia, oxygen suddenly floods damaged tissues. This burst of oxygen rapidly generates large amounts of reactive oxygen species. Paradoxically, restoring blood flow can worsen cellular injury. Several important reactive oxygen species molecules are involved. One is the superoxide anion, written as O2-. It is often the first free radical produced inside cells. Mitochondria are a major source of superoxide. Another important reactive oxygen species is hydrogen peroxide, or H2O2. Hydrogen peroxide is not technically a free radical, but it is still highly dangerous. It can easily cross cell membranes and spread injury. Then comes the hydroxyl radical, written as OH-1. This is one of the most reactive and destructive molecules in biology. Even tiny amounts can cause severe cellular damage. Reactive oxygen species attack many critical cellular components. They damage membrane lipids through lipid peroxidation. Cell membranes become fragile and leaky. Reactive oxygen species also attack proteins. Enzymes lose their normal structure and function. Structural proteins begin to malfunction. DNA is another major target. Reactive oxygen species can cause strand breaks and mutations. If the damage is severe, apoptosis may be triggered. Mitochondria are especially vulnerable to oxidative stress. Reactive oxygen species damage mitochondrial membranes and impair ATP production. The cell gradually loses its energy supply. Fortunately, cells have antioxidant defense systems. Superoxide dismutase converts superoxide into hydrogen peroxide. Catalase and glutathione peroxidase then neutralize hydrogen peroxide. Antioxidant vitamins also help. Vitamin E protects membranes. Vitamin C scavenges free radicals in the cytoplasm. But when reactive oxygen species production overwhelms these defenses, injury progresses rapidly. Membranes fail, proteins denature, DNA breaks apart, and eventually, the cell may die. Cells are constantly exposed to reactive oxygen species, or ROS. These molecules are produced every day during normal metabolism. So the body needs powerful defense systems to stay protected. That protection comes from antioxidant defense systems. These systems neutralize free radicals before they can damage the cell. They act like the body's internal cleanup crew. Some antioxidants are enzymes. Others are vitamins and small protective molecules. Together, they maintain cellular balance and stability. One of the most important enzymes is superoxide dismutase, or SOD. Superoxide dismutase is often the first line of defense against free radicals. It converts the dangerous superoxide anion into hydrogen peroxide. Now, hydrogen peroxide is still harmful, so the cell must quickly remove it. That is where catalase becomes important. Catalase is found mainly inside peroxisomes. It rapidly converts hydrogen peroxide into water and oxygen. This reaction prevents buildup of toxic peroxide inside the cell. Another critical enzyme is glutathione peroxidase. This enzyme also destroys hydrogen peroxide, but it has an additional role. It removes lipid peroxides from cell membranes. Glutathione peroxidase depends on glutathione to function properly. Glutathione is one of the cell's most important antioxidants. It is present in high concentrations inside healthy cells. Glutathione acts like an electron donor. It neutralizes reactive oxygen species directly. Then it gets regenerated and used again. The body also relies on non-enzymatic antioxidants. These include vitamins A, C, and E. Each works in a slightly different way. Vitamin E mainly protects cell membranes. It interrupts lipid peroxidation reactions. This helps preserve membrane integrity. Vitamin C works mostly in aqueous environments like the cytoplasm. It scavenges free radicals before they damage proteins or DNA. It can also help regenerate vitamin E. Vitamin A contributes to antioxidant defense too. It helps stabilize cellular structures and neutralize reactive molecules. All these systems work together continuously. They maintain a delicate balance between oxidants and antioxidants. Under normal conditions, the balance is tightly controlled. But sometimes reactive oxygen species production becomes excessive, or antioxidant defenses become depleted. That imbalance leads to oxidative stress. Oxidative stress damages lipids, proteins, and DNA. Membranes become leaky. Enzymes lose function. Genetic material becomes unstable. This process contributes to many diseases. It plays a role in aging, cancer, atherosclerosis, diabetes mellitus, and neurodegenerative disorders. In ischemia reperfusion injury, oxidative stress becomes especially severe. Sudden oxygen delivery creates a burst of free radicals. Cells may die even after blood flow is restored. So antioxidant defense systems are essential for survival. They constantly protect cells from invisible molecular damage. Without them, normal metabolism itself would become destructive. Lipid peroxidation is one of the most destructive effects of free radical injury. It mainly targets the cell membrane. And once it begins, the damage can spread very rapidly. Cell membranes are rich in phospholipids. Many of these phospholipids contain polyunsaturated fatty acids. These fatty acids have multiple double bonds. Those double bonds are weak points. Free radicals are strongly attracted to them. So membranes become prime targets during oxidative stress. The process usually starts with reactive oxygen species, or ROS. Hydroxyl radicals are especially dangerous. They attack the double bonds in membrane lipids. This attack removes a hydrogen atom from the lipid molecule. The lipid then becomes unstable. A lipid radical is formed. Now the chain reaction begins. The unstable lipid reacts with oxygen. This creates a lipid peroxide radical. That new radical attacks nearby lipids. More radicals are generated. More membrane lipids become damaged. This is why lipid peroxidation is called a self-propagating chain reaction. One free radical can trigger widespread membrane destruction. The reaction keeps spreading like falling dominoes. As lipid peroxidation continues, the membrane loses integrity. It becomes fragile and leaky. Normal membrane function starts to fail. The plasma membrane is heavily affected. Ions begin leaking across the membrane uncontrollably. Calcium enters the cell in excessive amounts. Cell swelling worsens. Membrane receptors and transport proteins also become damaged. The cell can no longer regulate its internal environment properly. Organelle membranes are injured too. Mitochondrial membranes become permeable. ATP production declines sharply. Energy failure soon follows. Damage to lysosomal membranes is especially dangerous. Hydrolytic enzymes leak into the cytoplasm. These enzymes begin digesting cellular components. The endoplasmic reticulum is also affected. Protein synthesis becomes impaired. Misfolded proteins begin accumulating inside the cell. Lipid peroxidation products themselves can also be toxic. Some form cross-links with proteins and DNA. This further disrupts normal cellular function. Normally, antioxidant systems help stop this process. Vitamin E is particularly important. It interrupts lipid peroxidation chain reactions inside membranes. Glutathione peroxidase also helps remove lipid peroxides. Together, antioxidants protect membrane stability. But when oxidative stress overwhelms these defenses, injury progresses rapidly. Membranes lose function, organelles fail, energy production collapses, and eventually, the cell may die. So lipid peroxidation is far more than simple membrane damage. It is a destructive chain reaction that spreads through the entire cell. And once severe membrane injury occurs, recovery becomes very difficult. Many drugs are safe when used correctly, but some drugs can become dangerous after metabolism inside the body. This is where drug-induced oxidative stress begins. The liver is the main site of drug metabolism. Hepatocytes contain enzyme systems that modify drugs to make them easier to eliminate. Most of the time, this process is protective. But sometimes metabolism creates reactive intermediates. These are unstable and highly reactive molecules. They can directly injure cellular structures. A classic example is acetaminophen. At normal doses, most acetaminophen is safely metabolized in the liver. It is conjugated and excreted without major problems. But a small portion is converted by cytochrome P450 enzymes into a toxic metabolite called NAPQI. Normally, this toxic intermediate is quickly neutralized. And that protection depends heavily on glutathione. Glutathione acts like the liver's chemical shield. It binds toxic intermediates and makes them harmless. This prevents oxidative injury inside hepatocytes. Problems occur during overdose or excessive exposure. Large amounts of NAPQI are produced rapidly. Glutathione stores become depleted. Once glutathione is exhausted, the toxic metabolites begin accumulating. Now the reactive intermediates start attacking cellular proteins and membranes directly. Oxidative stress rises dramatically. Reactive oxygen species, or ROS, increase rapidly. Mitochondria become major targets of injury. ATP production begins to fail. Membrane lipids undergo peroxidation. Proteins lose their normal structure. DNA may also become damaged. Calcium homeostasis collapses as membranes lose integrity. More destructive enzymes become activated inside the cell. The hepatocyte enters a state of severe metabolic crisis. Mitochondrial dysfunction worsens oxidative stress even further. A vicious cycle develops. Eventually, large numbers of liver cells die. This leads to hepatotoxicity. In severe cases, massive hepatic necrosis can occur. Clinically, patients may develop nausea, vomiting, and right upper quadrant pain. Liver enzymes begin rising sharply. If untreated, acute liver failure may follow. One reason acetaminophen toxicity is so dangerous is the delayed presentation. A patient may initially look stable, but severe liver injury may already be developing silently. Fortunately, treatment is available if given early. N-acetylcysteine helps replenish glutathione stores. This restores the liver's antioxidant defenses. Early treatment can dramatically reduce liver damage, but delayed treatment increases the risk of irreversible injury. Drug-induced oxidative stress is not limited to acetaminophen alone. Many drugs, toxins, and chemicals can generate reactive intermediates. Some anti-cancer drugs do this intentionally to kill tumor cells. So the balance between metabolism and antioxidant defense is critical. When toxic intermediates overwhelm glutathione protection, oxidative stress rapidly destroys cells. And in the liver, that damage can become life-threatening very quickly. Proteins are essential for almost every cellular function. They act as enzymes, receptors, transport channels, and structural supports. So when proteins become damaged, the entire cell begins to struggle. One major cause of protein injury is reactive oxygen species, or ROS. These highly reactive molecules can attack proteins directly. This process is called oxidative protein modification. Reactive oxygen species mainly target amino acid side chains. Certain amino acids are especially vulnerable to oxidation. Examples include cysteine, methionine, tyrosine, and histidine. When these side chains are oxidized, the protein's structure begins to change. And protein structure is everything. A protein must fold into a very precise shape to function properly. Even small structural changes can cause major problems. The protein may lose stability. It may stop interacting normally with other molecules. Enzymes are particularly sensitive. Oxidative damage can alter the active site of an enzyme. As a result, the enzyme can no longer catalyze reactions efficiently. Metabolic pathways begin slowing down. Cellular repair systems become impaired. Energy production may also decline. Some oxidized proteins become misfolded. Instead of folding correctly, they twist into abnormal shapes. The cell recognizes these proteins as defective. Normally, cells have quality control systems. Chaperone proteins help refold damaged proteins. Proteasomes help degrade proteins that cannot be repaired. But during severe oxidative stress, these systems become overwhelmed. Misfolded proteins begin accumulating inside the cell. Protein aggregates may start forming. These aggregates are toxic. They interfere with normal cellular function. They may disrupt organelles and intracellular transport systems. The endoplasmic reticulum becomes heavily stressed. This activates the unfolded protein response. If the stress becomes excessive, apoptosis may be triggered. Protein oxidation also contributes to cellular aging. Over time, oxidative damage accumulates gradually inside tissues. Cells become less efficient at repair and regeneration. Mitochondria become less effective. Enzyme systems slow down. Proteins lose flexibility and function. This progressive molecular damage is closely linked to degenerative diseases. In neurodegenerative disorders, abnormal protein accumulation is a major feature. For example, oxidative stress contributes to protein misfolding in Alzheimer's disease. Abnormal protein aggregates accumulate in the brain over many years. Neurons gradually lose function and die. Similar mechanisms are involved in Parkinson's disease and other chronic disorders. Oxidative protein injury also contributes to cardiovascular disease and diabetes complications. Fortunately, antioxidant systems help limit this damage. Glutathione, vitamin C, and vitamin E help neutralize reactive oxygen species before proteins are attacked. But when oxidative stress overwhelms these defenses, protein injury spreads rapidly. Enzymes fail. Protein aggregates accumulate. Cellular communication breaks down. And over time, tissues begin to degenerate. So reactive oxygen species do far more than damage membranes and DNA. They also silently alter the proteins that keep cells alive and functioning properly. DNA carries the genetic instructions that keep the cell alive and functioning properly. So when DNA becomes damaged, the consequences can be very serious. One major cause of DNA injury is reactive oxygen species, or ROS. Reactive oxygen species are highly reactive molecules generated during normal metabolism. In small amounts, cells can control them effectively. But excessive reactive oxygen species production creates oxidative stress. Under oxidative stress, free radicals begin attacking important cellular components. DNA is one of their major targets. Both nuclear DNA and mitochondrial DNA can be affected. Certain DNA bases are especially vulnerable. Thymine is one important target of free radical attack. Hydroxyl radicals can react directly with thymine molecules. This alters the normal chemical structure of DNA. The DNA strand becomes unstable. Errors begin appearing within the genetic material. Reactive oxygen species can also attack the sugar phosphate backbone of DNA. This weakens the physical structure of the strand itself. Eventually, breaks may develop in the DNA chain. One common injury is the single-strand break. Only one side of the DNA double helix is disrupted. But even this type of damage can interfere with normal cell function. DNA replication becomes difficult. Transcription may become abnormal. Protein synthesis may also be disrupted. Fortunately, cells have repair systems. DNA repair enzymes constantly scan the genome for damage. Small injuries can often be corrected successfully, but severe oxidative stress overwhelms these repair mechanisms. Too many DNA lesions begin accumulating. Genetic stability starts breaking down. Mitochondrial DNA is especially vulnerable. Unlike nuclear DNA, mitochondrial DNA has fewer protective mechanisms. And mitochondria are major sources of reactive oxygen species production. As mitochondrial DNA becomes damaged, energy production declines further. More reactive oxygen species are generated. A vicious cycle of oxidative injury develops. If DNA damage becomes extensive, the cell may activate apoptosis. This is a protective mechanism. The body eliminates severely damaged cells before they become dangerous. Proteins like p53 help monitor DNA integrity. When repair is impossible, p53 can trigger programmed cell death. But sometimes damaged cells survive instead of dying. Mutations remain permanently inside the genome. Over time, these mutations may accumulate. This is one reason oxidative stress is strongly linked to carcinogenesis. DNA mutations can activate oncogenes or disable tumor suppressor genes. Normal growth control mechanisms become disrupted. Eventually, uncontrolled cellular proliferation may develop. This is the foundation of cancer formation. Oxidative DNA damage also contributes to aging and degenerative diseases. Cells gradually lose genetic stability over many years. Repair systems become less efficient with age. Antioxidant defenses help reduce this damage. Glutathione, vitamin C, and antioxidant enzymes neutralize reactive oxygen species before they attack DNA. But when oxidative stress overwhelms these defenses, DNA injury spreads rapidly. Mutations accumulate, cell death increases, and the risk of malignant transformation rises significantly. So reactive oxygen species do not only damage membranes and proteins. They can directly alter the genetic blueprint of the cell itself. Reversible cell injury is the stage where a damaged cell is still capable of recovery. The injury is serious, but not yet permanent. If the stress is removed early enough, the cell can return to normal function. One of the earliest hallmarks is cellular swelling. This is often the very first visible sign of injury. It mainly happens because the cell loses control of ion balance. Normally, the sodium-potassium ATPase pump maintains proper ion distribution. This pump depends heavily on ATP, but during injury, ATP production falls. Without enough ATP, the ion pumps begin failing. Sodium starts accumulating inside the cell. Water follows sodium by osmosis. As water enters, the cell begins to swell. The cytoplasm becomes pale and enlarged. Organelles also start swelling. The endoplasmic reticulum may become distended. Mitochondria may appear swollen as well. This stage is sometimes called hydropic change. Despite the swelling, the membrane is still intact. That is why the injury is considered reversible. The cell is struggling, but not yet dead. Another important hallmark is fatty change, also called steatosis. This is especially common in organs involved in lipid metabolism. The liver is the classic example. Under normal conditions, hepatocytes process and export fats efficiently. But injured cells lose this metabolic control. Triglycerides begin accumulating inside the cytoplasm. Small lipid vacuoles appear within the cell. Over time, these vacuoles may enlarge and merge together. The cell develops a fatty appearance. Fatty change is commonly associated with alcohol toxicity, obesity, diabetes, and hypoxia. Some drugs and toxins can also trigger steatosis. If the underlying cause is corrected early, the fatty change may completely reverse. But persistent injury can eventually progress to irreversible damage. Membrane blebbing is another characteristic feature of reversible injury. The plasma membrane begins forming small protrusions or bulges. This happens because the cytoskeleton becomes weakened. ATP depletion and calcium influx contribute to cytoskeletal damage. Structural proteins begin losing stability. The membrane starts appearing irregular and distorted. Even though blebbing looks dramatic, the membrane may still remain unbroken at this stage. That distinction is very important. An intact membrane means recovery is still possible. Ribosomal detachment is another key change. Normally, ribosomes are attached to the rough endoplasmic reticulum. This is where protein synthesis occurs. During injury, ribosomes detach from the endoplasmic reticulum. Protein synthesis declines sharply. The cell can no longer produce proteins efficiently. This affects repair mechanisms and normal metabolism. Essential enzymes and structural proteins are not replaced properly. So reversible injury represents a critical turning point. The cell shows clear signs of stress and dysfunction. Swelling develops. Fat accumulates. Membranes begin deforming. Protein synthesis declines. But as long as severe membrane damage and nuclear destruction have not occurred, recovery is still possible. Irreversible cell injury is the stage where recovery is no longer possible. The damage has crossed a critical threshold. Even if the original cause is removed, the cell cannot survive. This is often called the point of no return. At this stage, essential cellular systems have failed permanently. Cell death becomes inevitable. One of the most important events is irreversible mitochondrial dysfunction. Mitochondria are the powerhouses of the cell. They generate ATP through oxidative phosphorylation. In early injury, mitochondrial damage may still be reversible. But severe injury causes permanent loss of mitochondrial function. ATP production collapses completely. Without ATP, The cell cannot maintain ion gradients. Membrane pumps stop working entirely. Calcium floods into the cytoplasm uncontrollably. Mitochondria also become major sources of reactive oxygen species. Oxidative stress increases dramatically. More proteins, lipids, and DNA become damaged. At this stage, mitochondrial membranes may develop large permeability defects. The mitochondria lose their membrane potential. Energy generation becomes impossible. Some mitochondria also release pro-apoptotic proteins like cytochrome C. This activates the apoptotic pathway. The cell begins programmed self-destruction. Another hallmark of irreversible injury is profound membrane damage. Cell membranes lose structural integrity completely. Small membrane blebs progress into full membrane rupture. The plasma membrane becomes leaky and fragmented. Important intracellular contents begin escaping into the extracellular space. This is why damaged tissues release diagnostic enzymes into the blood. For example, injured cardiac muscle releases troponins during myocardial infarction. Damaged hepatocytes release liver enzymes like AST and ALT. Organelle membranes also rupture. Mitochondrial membranes fail completely. The endoplasmic reticulum becomes fragmented. Lysosomal membrane rupture is especially destructive. Lysosomes contain powerful hydrolytic enzymes. These enzymes are normally kept safely enclosed. But when lysosomal membranes rupture, the enzymes leak into the cytoplasm. Now the cell begins digesting itself from within. This process is called enzymatic autodigestion. Proteases break down proteins. Nucleases fragment DNA and RNA. Lipases digest membrane lipids. The cytoplasm becomes increasingly disorganized. Organelles lose recognizable structure. The nucleus also begins to deteriorate. Nuclear changes are classic signs of irreversible injury. The nucleus may shrink, a process called pagnosis. Then it may fragment, called karyopexis. Eventually, it dissolves completely in karyolysis. At this stage, the cell is no longer viable. Metabolism has stopped. Membranes are destroyed. Genetic material is fragmented. The final outcome is cell death, usually by necrosis or apoptosis. Necrosis often triggers inflammation because cellular contents spill into surrounding tissues. Apoptosis, in contrast, is usually more controlled and less inflammatory. So irreversible injury represents catastrophic cellular failure. Mitochondria can no longer produce energy. Membranes rupture extensively. Lysosomal enzymes digest the cell internally. And once this threshold is crossed, survival is no longer possible. When cells become injured, they do not only change functionally, they also begin changing structurally. These visible structural changes are called morphologic changes. One of the earliest and most important features is cellular swelling. The injured cell starts accumulating water inside the cytoplasm. This usually happens because ATP production falls. Without enough ATP, sodium-potassium pumps begin failing. Sodium accumulates inside the cell. Water follows sodium into the cytoplasm. The cell gradually enlarges and becomes swollen. Organelles also begin swelling. This process is still considered reversible at this stage. Under light microscopy, this swelling often appears as clear vacuoles in the cytoplasm. These vacuoles represent distended organelles filled with water. This appearance is called hydropic change. Hydropic change is one of the classic signs of reversible injury. The cytoplasm may look pale, cloudy, and vacuolated. The normal architecture of the cell begins to blur slightly. The endoplasmic reticulum becomes swollen. Mitochondria may also appear enlarged. Protein synthesis starts slowing down. Electron microscopy reveals even more detailed changes. At this level, the ultrastructure of the cell becomes visible. One early finding is blunting of microvilli. Normally, microvilli increase the cell's surface area. They are especially important in absorption and transport. During injury, microvilli become shortened and flattened. This reduces the cell's functional efficiency. The plasma membrane begins losing its normal organization. Membrane blebbing is another major feature. Small bubble-like protrusions form along the cell membrane. These blebs develop because the cytoskeleton becomes weakened. ATP depletion and calcium influx damage cytoskeletal proteins. The membrane loses stable support underneath. As a result, portions of the membrane bulge outward. Despite these changes, the membrane may still remain intact initially. That is why recovery is still possible during reversible injury. Mitochondria under electron microscopy may show swelling and distorted cristae. The endoplasmic reticulum may appear dilated. Ribosomes may detach from the rough ER. This ribosomal detachment reduces protein synthesis significantly. The cell can no longer maintain normal repair processes efficiently. These microscopic changes also affect the entire organ. At the gross level, injured organs may become swollen and pale. This happens because of increased water accumulation and impaired circulation. The tissue often appears softer and heavier than normal. The pallor reflects reduced oxygenation and altered blood flow. For example, an injured kidney may look enlarged and pale during ischemic injury. The liver may also appear swollen in toxic or hypoxic damage. These gross and microscopic findings help pathologists identify early cell injury. They provide important clues about the severity and reversibility of damage. So swelling and blebbing are not random abnormalities. They are visual signs of cellular stress and energy failure. And they often represent the earliest morphologic evidence that a cell is struggling to survive. The nucleus is the control center of the cell. It contains the genetic material needed for survival and normal function. So when the nucleus begins changing during injury, it is a serious warning sign. Nuclear changes are especially important in irreversible cell injury and cell death. Pathologists often examine these changes carefully under the microscope. They help determine how severe the injury has become. There are three classic nuclear changes seen in cell injury. These are pyknosis, karyorrhexis, and karyolysis. They often occur in sequence as the cell progresses toward death. The first change is pyknosis. Pyknosis means nuclear shrinkage. The nucleus becomes smaller and darker than normal. This happens because chromatin condenses tightly together. The DNA becomes densely packed inside the nucleus. As a result, the nucleus stains more intensely with basic dyes. This increased staining is called basophilia. Under the microscope, the nucleus appears small, dark, and hyperchromatic. It looks dense and compact. Pyknosis usually indicates severe cellular stress. The cell is losing its ability to maintain normal nuclear structure. At this stage, irreversible injury is often already developing. The next stage is karyorrhexis. This means fragmentation of the pyknotic nucleus. The condensed nucleus begins breaking apart into smaller pieces. The nuclear membrane loses integrity. Chromatin fragments scatter throughout the cytoplasm. The nucleus no longer appears as a single organized structure. Under the microscope, the cell contains multiple dark nuclear fragments. This is a strong sign that the cell is undergoing irreversible injury or death. Eventually, the process progresses to karyolysis. This means dissolution or fading of the nucleus. The chromatin gradually disappears. Karyolysis occurs because DNA is digested by enzymes called DNases. These enzymes break down nuclear DNA progressively. The chromatin loses its staining ability. As the DNA dissolves, the nucleus becomes pale and ghost-like. Eventually, the nucleus may disappear completely. At this point, the cell is dead. These nuclear changes are commonly seen in necrosis. They help pathologists identify dead or dying cells in tissue sections. For example, in ischemic injury, cells deprived of oxygen often progress through these stages. The nucleus first shrinks, then fragments, and finally dissolves. Similar nuclear changes can also occur in toxic injury and severe infections. They are hallmarks of irreversible cellular damage. The sequence is important to remember. Pagnosis comes first, then karyorexis follows. Finally, karyolysis occurs. Together, these changes reflect progressive destruction of the genetic material. The cell loses the ability to control metabolism, repair damage, and reproduce. So nuclear changes are not just microscopic details. They are visual evidence that the cell's genetic control center is collapsing. And once the nucleus is destroyed, recovery is no longer possible. Cells can die in different ways. The two major forms of cell death are necrosis and apoptosis. Both occur after irreversible injury, but they are very different processes. Necrosis is often described as accidental cell death. It usually happens after severe injury or overwhelming stress. The cell loses control of its internal environment completely. Common causes include ischemia, toxins, infections, and trauma. ATP production collapses. Membranes rupture. Organelles fail. As the plasma membrane breaks apart, cellular contents spill into surrounding tissues. These leaked contents act as danger signals to the body. The immune system reacts immediately. This reaction triggers inflammation. Neutrophils and macrophages move into the damaged tissue. Swelling, redness, heat, and pain may follow. That is why necrosis is always considered pathologic. It reflects uncontrolled and damaging cell death. The surrounding tissue is often injured as well. Under the microscope, necrotic cells appear swollen and disorganized. Membranes are ruptured. The cytoplasm becomes intensely eosinophilic. Nuclear changes like pagnosis, karyorexis, and karyolysis are common. Necrosis often affects groups of neighboring cells together. For example, during myocardial infarction, large areas of cardiac muscle undergo necrosis after loss of blood supply. Apoptosis is very different. It is called programmed cell death. This process is highly regulated and controlled. Instead of chaotic destruction, apoptosis follows an organized sequence of events. The cell essentially activates its own self-destruction program. Apoptosis can occur in both normal physiology and disease. In normal development, apoptosis helps shape organs and remove unnecessary cells. For example, it separates fingers during embryonic development. It also removes old or damaged cells routinely. Cells with severe DNA damage may undergo apoptosis to prevent cancer formation. Unlike necrosis, apoptosis does not usually trigger inflammation. That is a major difference. During apoptosis, the cell shrinks rather than swells. Chromatin condenses neatly inside the nucleus. The membrane remains intact for most of the process. The cell breaks into small membrane-bound fragments called apoptotic bodies. These fragments are rapidly removed by phagocytic cells. Very little cellular material leaks into surrounding tissues. Because the contents stay contained, the immune system is not strongly activated. The tissue remains relatively clean and quiet. Apoptosis depends heavily on enzymes called caspases. These enzymes systematically dismantle the cell from within. DNA is fragmented in a controlled manner. Necrosis and apoptosis may sometimes occur together in the same disease process. Severe injury often favors necrosis. Milder but irreversible damage may activate apoptosis instead. So both are final outcomes of irreversible injury. But necrosis is chaotic, inflammatory, and destructive. Apoptosis is organized, controlled, and usually non-inflammatory. Understanding this difference is very important in pathology. It helps explain how tissues respond to injury, infection, toxins, and even cancer therapy. Necrosis is a form of uncontrolled cell death caused by severe injury. It occurs when damage becomes too extensive for the cell to recover. The cell loses the ability to maintain normal structure and function. One of the most important features of necrosis is loss of membrane integrity. The plasma membrane becomes severely damaged and eventually ruptures. This is a critical event in necrotic cell death. Normally, the cell membrane carefully controls what enters and leaves the cell. It maintains ion balance and protects intracellular contents. But during necrosis, this barrier completely fails. ATP depletion plays a major role. Without energy, membrane pumps stop functioning properly. Calcium accumulates inside the cell. Excess calcium activates destructive enzymes. Proteases damage structural proteins. Phospholipases attack membrane phospholipids. The membrane becomes increasingly fragile and leaky. Reactive oxygen species worsen the injury further. Lipid peroxidation damages membrane lipids extensively. Eventually, the membrane ruptures completely. Once rupture occurs, cellular contents leak into surrounding tissues. Enzymes, proteins, and intracellular molecules spill into the extracellular space. This leakage is one reason necrosis can be detected clinically. For example, necrotic cardiac muscle releases troponins into the bloodstream during myocardial infarction. Damaged liver cells release AST and ALT during hepatocellular injury. The leaked cellular contents are highly inflammatory. They act as danger signals to the immune system. Nearby tissues recognize them as signs of damage. An inflammatory response quickly develops around the necrotic area. Blood vessels dilate. Immune cells migrate into the tissue. Swelling and redness may occur. Neutrophils are usually among the first cells to arrive. They begin clearing dead tissue and cellular debris. Macrophages later help remove necrotic remnants. This inflammatory reaction can sometimes cause additional tissue injury. Enzymes and reactive oxygen species released by inflammatory cells may damage nearby healthy cells too. Another important feature of necrosis is that it usually affects large groups of cells. Necrosis often occurs in areas exposed to the same severe injury. For example, loss of blood supply may kill an entire region of tissue simultaneously. This is very different from apoptosis, which often affects isolated individual cells. Under the microscope, necrotic cells appear swollen and disorganized. The cytoplasm becomes intensely pink and eosinophilic. Membranes are disrupted. Nuclear changes are also prominent. The nucleus may shrink in pagnosis, then fragment during karyopexis. Finally, it dissolves through karyolysis. Different types of necrosis exist depending on the tissue and cause. Examples include coagulative necrosis, liquefactive necrosis, caseous necrosis, and fat necrosis. But all forms share the same core features: loss of membrane integrity, leakage of intracellular contents, inflammation, and widespread cell death. So necrosis represents catastrophic cellular failure. The cell loses all control over its internal environment. Its contents spill outward, inflammation follows, and surrounding tissues are often affected as well. Coagulative necrosis is the most common type of necrosis seen in solid organs. It usually develops after sudden loss of blood supply, also called infarction. The classic organs involved are the heart and kidneys. When blood flow stops, oxygen delivery falls rapidly. Cells can no longer produce enough ATP. Energy-dependent processes begin failing. Without oxygen, mitochondria stop functioning properly. Ion pumps collapse. Calcium accumulates inside cells. Severe injury quickly develops. Eventually, the affected cells die. But coagulative necrosis has a very unique appearance. Even though the cells are dead, the overall tissue structure remains preserved for some time. This preservation of architecture is the hallmark of coagulative necrosis. Under the microscope, the outlines of the dead cells are still visible. The tissue looks like a ghost version of the original organ. The cells lose nuclei and normal function, but the basic shape of the tissue remains recognizable for several days. Why does this happen? The answer lies in protein denaturation. During severe ischemic injury, structural proteins become denatured. Enzymes inside the cells are also denatured. This is very important. Normally, enzymes digest dead cellular material through proteolysis. But when those enzymes themselves become denatured, proteolysis is blocked or slowed greatly. As a result, dead cells are not broken down immediately. The tissue architecture remains temporarily intact. This creates the classic appearance of coagulative necrosis. Under light microscopy, the cytoplasm appears intensely eosinophilic and pink. The cells often look swollen and glassy. Nuclei disappear because of pyknosis, karyorrhexis, and eventually karyolysis. Inflammation soon develops around the necrotic area. Neutrophils begin infiltrating the damaged tissue. Later, macrophages arrive to remove the necrotic debris. Over time, the dead tissue is gradually digested and replaced by scar tissue. Fibrosis commonly follows healing in solid organs. A classic clinical example is myocardial infarction. When a coronary artery becomes blocked, part of the heart muscle loses blood supply. The affected cardiac muscle undergoes coagulative necrosis. The dead myocardial cells maintain their outlines initially, but they can no longer contract or generate energy. Inflammatory cells later clear the necrotic tissue. Coagulative necrosis also occurs in renal infarction. A blocked renal artery can produce wedge-shaped areas of pale necrotic tissue in the kidney. Interestingly, the brain is a major exception. Ischemic injury in the brain usually produces liquefactive necrosis instead of coagulative necrosis. So coagulative necrosis is strongly associated with ischemia in solid tissues. Its defining feature is preservation of tissue architecture despite cell death. This occurs because protein and enzyme denaturation slows cellular digestion. The tissue may look structurally intact for days, but functionally, the cells are already dead. Liquefactive necrosis is a type of cell death where dead tissue is completely digested into a liquid mass. Instead of preserving tissue structure, the tissue becomes soft, viscous, and liquefied. This form of necrosis looks very different from coagulative necrosis. The key feature is enzymatic digestion of dead cells. Hydrolytic enzymes break down cellular material rapidly and extensively. The tissue essentially dissolves. Liquefactive necrosis is especially common in bacterial and fungal infections. Microorganisms trigger a strong inflammatory response. Large numbers of neutrophils migrate into the infected tissue. Neutrophils contain powerful digestive enzymes. These enzymes are released to destroy invading microbes. But they also digest surrounding host tissue. As digestion continues, the dead tissue becomes liquid and creamy. This material is commonly called pus. Pus contains dead leukocytes, tissue debris, and microorganisms. An abscess is a classic example. A localized bacterial infection may create a cavity filled with pus. The surrounding tissue becomes inflamed and swollen. Under the microscope, normal tissue architecture is completely lost. Instead of preserved cell outlines, there is amorphous granular debris. The area often appears filled with neutrophils and fluid material. Liquefactive necrosis also occurs in the brain after hypoxic or ischemic injury. This is a very important exception in pathology. Most solid organs develop coagulative necrosis after ischemia. But the brain behaves differently. When brain tissue loses blood supply, neurons die rapidly. Enzymatic digestion dominates the process. The dead neural tissue becomes liquefied over time. Why does the brain undergo liquefactive necrosis? Brain tissue contains abundant lipids and hydrolytic enzymes. It also has relatively little supportive connective tissue. As the necrotic tissue is digested, a cystic cavity may eventually form. Macrophages gradually remove the liquefied debris. The remaining space may persist as a fluid-filled cavity. Clinically, liquefactive necrosis in the brain can occur after stroke. An ischemic infarction may initially cause swelling and inflammation. Days later, the tissue softens and liquefies progressively. The process can increase intracranial pressure and worsen neurologic damage. That is why cerebral infarction can become life-threatening. In infections, liquefactive necrosis may spread rapidly if untreated. Large abscesses can destroy surrounding tissue extensively. Drainage and antimicrobial therapy are often necessary. Grossly, liquefactive necrosis appears soft, yellowish, and fluid-filled. The tissue loses firmness completely. The affected area may resemble thick creamy liquid. So the hallmark of liquefactive necrosis is complete digestion of dead cells. Instead of preserving tissue structure, the tissue is transformed into liquid debris. This process is strongly associated with infections and ischemic injury in the brain. It represents one of the most destructive forms of tissue necrosis. Not all necrosis looks the same under the microscope. Different injuries produce different patterns of tissue death. Two important examples are caseous necrosis and fat necrosis. Caseous necrosis is classically associated with tuberculosis. It is commonly seen inside granulomas formed during chronic infection. The term, caseous, comes from the word cheese. Grossly, the necrotic tissue appears soft, white, and crumbly. It resembles cottage cheese in appearance. That is why it is called cheese-like necrosis. This type of necrosis develops because of a strong immune response against persistent pathogens. Macrophages and T lymphocytes surround the infected area. A granuloma forms to contain the infection. Inside the granuloma, severe tissue destruction occurs. The dead cells lose all normal architecture. Unlike coagulative necrosis, the tissue outlines are not preserved clearly. Under the microscope, caseous necrosis appears as amorphous granular debris. The center looks eosinophilic and structureless. Surrounding inflammatory cells and giant cells often form a rim around it. Although tuberculosis is the classic example, some fungal infections can also produce caseous necrosis. Fat necrosis is very different. It involves focal destruction of adipose tissue. This type is strongly associated with acute pancreatitis. In pancreatitis, pancreatic enzymes leak out into surrounding tissues. One important group of enzymes is lipases. Lipases digest triglycerides inside fat cells. As fat cells break down, free fatty acids are released. These fatty acids are highly reactive. They combine with calcium ions in the tissue. This process is called saponification. Essentially, calcium and fatty acids form soap-like deposits. These deposits appear as chalky white areas grossly. Saponification is a classic hallmark of fat necrosis. It is especially common around the pancreas during severe pancreatitis. Under the microscope, necrotic fat cells lose their nuclei. The adipocytes appear shadowy and disrupted. Basophilic calcium deposits may also be visible. Inflammation develops around the damaged fat tissue. Macrophages and giant cells may accumulate over time. Fibrosis can occur during healing. Fat necrosis can also occur after trauma, especially in breast tissue. Injury to adipose tissue may trigger local fat destruction and inflammation. Sometimes it can mimic a tumor clinically. Clinically, severe pancreatitis with fat necrosis can become life-threatening. Enzyme release may cause widespread tissue injury and systemic inflammation. Calcium levels in the blood may also fall because calcium becomes trapped in saponified fat. Caseous necrosis and fat necrosis represent two distinct patterns of tissue injury. Caseous necrosis produces soft cheese-like granulomatous debris, especially in tuberculosis. Fat necrosis destroys adipose tissue through enzymatic digestion and saponification. Both patterns help pathologists identify the underlying disease process causing tissue damage. Apoptosis is a highly organized form of programmed cell death. Unlike necrosis, it is controlled, regulated, and energy-dependent. The cell essentially activates its own self-destruction program. This process is extremely important for normal health and development. The body uses apoptosis every day to remove unwanted or damaged cells. Without it, abnormal cells could accumulate dangerously. During embryonic development, apoptosis helps shape organs and tissues. For example, it separates the fingers and toes before birth. It also removes excess cells during tissue remodeling. Apoptosis is also a protective mechanism. Cells with severe DNA damage may undergo apoptosis to prevent cancer formation. Virus-infected cells may also be eliminated this way. One major feature of apoptosis is regulation. Specific signaling pathways control the entire process carefully. Special enzymes called caspases play a central role. Caspases act like molecular scissors. Once activated, they systematically dismantle the cell from within. Proteins, cytoskeletal structures, and nuclear material are broken down in an organized sequence. Unlike necrosis, the plasma membrane remains intact during apoptosis. This is a very important distinction. The membrane undergoes changes, but it does not rupture suddenly. Because the membrane stays intact, cellular contents do not leak into surrounding tissues. That means nearby cells are protected from inflammatory damage. As apoptosis progresses, the cell begins shrinking. The cytoplasm becomes dense. Chromatin condenses inside the nucleus. The nucleus may fragment in a controlled manner. The cell membrane forms small blebs along its surface. But again, the membrane integrity is largely maintained. Eventually, the dying cell breaks apart into smaller membrane-bound fragments. These are called apoptotic bodies. Each apoptotic body contains portions of cytoplasm and nuclear material. These fragments are quickly recognized by phagocytic cells. Macrophages and neighboring cells engulf them efficiently. The cellular debris is removed quietly and cleanly. Because there is minimal leakage of intracellular contents, Apoptosis does not trigger significant inflammation. This is one of its most important characteristics. The surrounding tissue remains relatively undisturbed. Under the microscope, apoptotic cells appear shrunken and intensely eosinophilic. Chromatin condensation is prominent. Small apoptotic bodies may also be visible. Apoptosis can occur through different pathways. The intrinsic pathway is triggered by internal cellular stress, especially mitochondrial damage. The extrinsic pathway is activated by death receptors on the cell's surface. Both pathways ultimately activate caspases and lead to orderly cell dismantling. Defects in apoptosis can contribute to disease. Too little apoptosis may allow cancer cells to survive abnormally. Too much apoptosis may contribute to degenerative diseases and tissue loss. So apoptosis is not simply cell death. It is a carefully controlled biologic process designed to protect the body. The cell dies quietly, its contents remain contained, apoptotic bodies are removed efficiently, and inflammation is largely avoided. The intrinsic pathway of apoptosis is also called the mitochondrial pathway. It is activated by internal cellular stress and damage. This pathway helps the body eliminate cells that are no longer safe to keep alive. One major trigger is DNA damage. Radiation, toxins, reactive oxygen species, and chemotherapy drugs can all injure DNA. When the damage becomes too severe, the cell may decide to self-destruct. Another trigger is loss of survival signals. Healthy cells constantly receive growth factors and survival signals from their environment. Without these signals, the cell senses danger and stress. The mitochondria play the central role in this pathway. Normally, mitochondria generate ATP and support cell survival. But during severe stress, they can also initiate apoptosis. A special group of proteins regulates this process. These proteins belong to the BCL2 family. Some members promote survival, while others promote apoptosis. Pro-apoptotic proteins include BAX and BAK. These proteins become activated during cellular stress. They move toward the outer mitochondrial membrane. Once activated, BAX and BAK create pores within the mitochondrial membrane. This is a critical turning point in apoptosis. The mitochondrial membrane becomes permeable. Now important proteins begin leaking out of the mitochondria. One of the most important is cytochrome C. Normally, cytochrome C helps with electron transport and ATP production. But once released into the cytoplasm, cytochrome C takes on a completely different role. It becomes a powerful activator of apoptosis. Cytochrome C binds to a protein called APAF1. Together, they form a large complex called the Apoptosome. This complex acts like an activation platform. The Apoptosome then activates caspase 9. Caspase 9 is called an initiator caspase. It starts the apoptotic enzyme cascade. Once caspase 9 is activated, it activates executioner caspases like caspase 3 and caspase 6. These enzymes systematically dismantle the cell. Structural proteins are degraded. DNA is fragmented. The cytoskeleton collapses. The nucleus condenses and breaks apart. Despite all this destruction, the plasma membrane remains mostly intact. That is why apoptosis does not usually trigger inflammation. The cell gradually shrinks and forms apoptotic bodies. These membrane-bound fragments are quickly removed by macrophages. The surrounding tissue remains relatively undisturbed. The intrinsic pathway is tightly regulated because apoptosis must be controlled carefully. Too little apoptosis may allow damaged cells to survive and become cancerous. Too much apoptosis may contribute to degenerative diseases. Anti-apoptotic proteins like BCL2 normally help stabilize the mitochondrial membrane. They prevent cytochrome C release under healthy conditions. The balance between pro-apoptotic and anti-apoptotic proteins determines the cell's fate. The tumor suppressor protein p53 is also very important. When DNA damage is severe, p53 promotes apoptosis by activating Bax and other pro-apoptotic proteins. So the intrinsic pathway acts like an internal safety system. When damage becomes irreversible, mitochondria help activate a controlled cell death program. Cytochrome C is released, Caspase-9 is activated, and the damaged cell is removed safely and efficiently. The extrinsic pathway of apoptosis is also called the death receptor pathway. Unlike the intrinsic pathway, this process begins outside the cell. External signals tell the cell that it is time to die. This pathway is very important in immune regulation and tissue homeostasis. It helps eliminate infected, damaged, or unnecessary cells safely. The process is highly controlled and tightly regulated. The pathway starts when special external ligands bind to death receptors on the cell's surface. Two important ligands are FAS ligand, called FASL, and tumor necrosis factor, or TNF. These ligands are often produced by immune cells. For example, cytotoxic T cells use FASL to destroy virus-infected cells. This helps protect the body from infection. The target cell contains specific death receptors on its membrane. Important examples include FAS, also called CD95, and TNF receptor 1, or TNFR1. When FASL or TNF binds to these receptors, the receptors begin clustering together. This clustering is a critical activation step. It changes the structure of the receptor complex. The clustered receptors then recruit adapter proteins inside the cell. One important adapter protein is FADD, which stands for FAS-associated death domain. These adapter proteins act like signaling bridges. Next, initiator caspases are recruited to the receptor complex. The most important one here is caspase 8. This enzyme becomes activated at the death-inducing signaling complex, often called the disc. Once caspase 8 is activated, the apoptotic cascade begins rapidly. This is a major turning point in the pathway. The cell is now committed to apoptosis. Caspase 8 directly activates executioner caspases such as caspase 3. These executioner caspases dismantle the cell systematically. Structural proteins are degraded. The cytoskeleton collapses. DNA becomes fragmented. The nucleus condenses and breaks apart. The cell gradually shrinks in size. Membrane blebs form along the surface. Eventually, the cell divides into apoptotic bodies. Throughout most of this process, the plasma membrane remains intact. Cellular contents stay contained inside membrane-bound fragments. That is why inflammation is usually avoided. Macrophages quickly recognize and engulf the apoptotic bodies. The dead cell is removed quietly and efficiently. Surrounding tissues remain largely unaffected. The extrinsic pathway can also interact with the intrinsic mitochondrial pathway. Activated caspases the 8th of May amplify apoptosis by influencing mitochondrial proteins like BID. This strengthens the death signal further. Defects in the extrinsic pathway can contribute to disease. If apoptosis fails, abnormal cells may survive longer than they should. This can contribute to cancer and autoimmune disease. Excessive activation, however, can also be harmful. Too much apoptosis may cause tissue damage and degenerative disorders. So the extrinsic pathway is essentially an externally controlled suicide program for the cell. External ligands activate death receptors. Death receptors activate caspases 8. And caspases 8 launches the execution phase of apoptosis in a rapid and organized manner. Apoptosis is carried out through a highly organized enzyme system called the caspase cascade. Caspases are specialized proteolytic enzymes. Their job is to dismantle the cell in a controlled and orderly way. The name, caspase, comes from cysteine aspartate protease. These enzymes cut proteins at specific sites. They exist inside healthy cells as inactive precursors called precaspases. When apoptosis is triggered, these inactive precaspases become activated. Once activated, the caspase cascade begins rapidly. One caspase activates another in a chain reaction. The cascade is divided into two major groups. Initiator caspases start the process. Executioner caspases carry out the destruction phase. The main initiator caspases are caspase 8 and caspase 9. Each is activated by a different apoptotic pathway. Caspase 8 is mainly associated with the extrinsic death receptor pathway. External signals like Fas ligand or TNF activate death receptors on the cell membrane. This eventually activates caspase 8. Caspase 9 is mainly linked to the intrinsic mitochondrial pathway. DNA damage and severe cellular stress trigger mitochondrial permeability changes. Cytochrome C is released into the cytoplasm. Cytochrome C combines with APAF1 to form the apoptosis. The apoptosis then activates caspase 9. Now the apoptotic machinery is fully engaged. Once initiator caspases are activated, they activate the executioner caspases. The most important executioner caspases are caspase 3, caspase 6, and caspase 7. These enzymes perform the actual dismantling of the cell. Executioner caspases target many important cellular proteins. They cleave cytoskeletal proteins first. The structural framework of the cell begins collapsing. The cell loses shape and stability. Membrane blebs begin forming. The cell gradually shrinks. Caspases also attack proteins inside the nucleus. They activate enzymes that fragment DNA. Chromatin condenses and breaks apart systematically. This controlled DNA cleavage is a hallmark of apoptosis. Unlike necrosis, the genetic material is dismantled in an organized manner. The membrane still remains mostly intact. Executioner caspases also disrupt repair enzymes and signaling proteins. The cell can no longer maintain normal metabolism or survival functions. Everything is progressively shut down. Eventually, the cell breaks into small membrane-bound apoptotic bodies. These fragments contain portions of cytoplasm and nuclear material. Macrophages quickly remove them through phagocytosis. Because the cellular contents stay enclosed, inflammation is usually avoided. This makes apoptosis a clean and controlled form of cell death. The caspase cascade is tightly regulated because inappropriate activation would be dangerous. Too little caspase activity may allow abnormal cells to survive, contributing to cancer. Too much activation may contribute to degenerative diseases and tissue loss. So the caspase cascade functions like a molecular demolition system. Initiator caspases receive the death signal. Executioner caspases dismantle the cell step by step. And the entire process occurs in a precise, organized, and non-inflammatory manner. When a cell is damaged beyond repair, the body activates a clean and organized process called apoptosis. This is often called programmed cell death. It allows old or injured cells to die without harming nearby tissues. During apoptosis, the dying cell breaks into small membrane-bound fragments. These fragments are called apoptotic bodies. They safely package the cell's contents before removal. One important change happens on the cell membrane. A molecule called phosphatidylserine flips from the inner surface to the outer surface. This acts like a distress signal to the immune system. Scientists call it an "eat me" signal. It tells nearby scavenger cells that this cell is ready to be removed. Macrophages quickly recognize this signal. Macrophages are specialized immune cells that clean up dead cells and debris. They move toward the apoptotic bodies and swallow them through a process called phagocytosis. This cleanup happens very fast and very efficiently. The contents of the dying cell stay sealed inside the membrane. Because of this, harmful enzymes and toxic substances do not leak into surrounding tissues. That is extremely important for preventing inflammation. Unlike uncontrolled cell death, apoptosis remains quiet and controlled. The surrounding tissue is protected from damage. This process happens constantly inside the human body. Millions of cells undergo apoptosis every single day. Old skin cells, immune cells, and damaged cells are routinely removed this way. Phagocytosis of apoptotic bodies is essential for healthy tissue maintenance. Without proper clearance, dead cells can accumulate and trigger inflammation or autoimmune reactions. So, apoptosis is not just cell death. It is a carefully coordinated cleanup system. The body removes unwanted cells while keeping nearby tissues safe and healthy. Pause the video and carefully scrutinize the table before progressing to the next slide. Pause the video and carefully scrutinize the table before progressing to the next slide. The decision between cell survival and cell death is tightly controlled inside the mitochondria. At the center of this control system is the BCL2 family of proteins. These proteins act like guards that determine whether a cell lives or undergoes apoptosis. Some members of the BCL2 family protect the cell. These are called anti-apoptotic proteins. The most important examples are BCL2 and BCLXL. Their main job is to keep the mitochondrial membrane stable. They prevent the release of cytochrome C, often called CYTC. As long as cytochrome C stays inside the mitochondria, apoptosis is blocked. You can think of BCL2 proteins as bodyguards for the cell. They help cells survive during mild stress or temporary injury. This protection is important for normal tissue function and healing. But not all BCL2 family proteins are protective. Some are designed to trigger apoptosis when damage becomes severe. These are called pro-apoptotic proteins. The key players here are BAX and BAK. When activated, they create openings in the mitochondrial membrane. This allows cytochrome C to leak out into the cytoplasm. Once cytochrome C is released, the cell activates caspases. These are powerful enzymes that dismantle the cell from within. At that point, apoptosis moves forward rapidly. Another group of proteins acts like cellular stress sensors. These are the BH3-only proteins, including BAD and BIM. They constantly monitor the health of the cell. When the cell experiences DNA damage, oxidative stress, or lack of nutrients, these proteins become activated. They detect when the cell is no longer safe to preserve. BH3-only proteins help shut down the protective effects of BCL2 and BCLXL. At the same time, they activate BAX and BAK. This shifts the balance toward apoptosis. So, the fate of the cell depends on balance. If survival proteins dominate, the cell stays alive. If death-promoting proteins take over, apoptosis begins. This balance is extremely important in human disease. Too much apoptosis can contribute to neurodegenerative disorders. Too little apoptosis can allow damaged cells to survive and become cancerous. In many cancers, BCL2 proteins are overactive. They prevent abnormal cells from dying when they should. That is why some modern cancer drugs specifically target BCL2 pathways. The BCL2 family is like a molecular switchboard for life and death. It constantly evaluates stress, damage, and survival signals inside every cell. The intrinsic pathway of apoptosis is the cell's internal self-destruct system. It is activated when the cell experiences severe stress or irreversible damage. One of the most common triggers is DNA damage. This pathway mainly centers around the mitochondria. The mitochondria are not only the cell's powerhouses. They also help decide whether a damaged cell should survive or die. The process begins when the cell senses danger. Stress signals may come from radiation, toxins, infections, or lack of oxygen. Severe DNA damage is one of the strongest triggers. Once stress is detected, BH3-only proteins become activated. These proteins act like cellular alarm sensors. Examples include BAD, BIM, and BID. Their job is to evaluate the condition of the cell. If the damage is too severe to repair, they push the cell toward apoptosis. They do this by activating BAX and BAK proteins. BAX and BAK move to the mitochondrial membrane. There, they form tiny pores or openings in the membrane surface. These pores change the permeability of the mitochondria. As the membrane becomes porous, cytochrome C escapes from the mitochondria into the cytosol. This is a major turning point in apoptosis. Once cytochrome C is released, the death pathway becomes difficult to stop. Inside the cytosol, cytochrome C binds with other proteins, including APAF1. Together, they assemble a large complex called the apoptosome. Think of the apoptosome as the cell's execution platform. The apoptosome activates caspase-9. Caspase-9 is known as an initiator caspase. Its role is to start the enzyme cascade of apoptosis. Activated caspase-9 then switches on caspase-3. Caspase-3 is one of the main executioner caspases. It begins breaking down essential cellular proteins and structures. The nucleus shrinks. DNA becomes fragmented. The cell membrane starts forming small blebs. Eventually, the cell breaks into apoptotic bodies. These fragments are quickly removed by macrophages. Importantly, the process remains controlled and clean. Unlike necrosis, the intrinsic pathway usually does not trigger inflammation. The cell dies quietly without damaging surrounding tissues. So, the intrinsic pathway is a carefully regulated defense mechanism. It removes cells that are too damaged to function safely. This helps protect the body from cancer, genetic mutations, and further tissue injury. The decision between cell survival and cell death is tightly controlled inside the mitochondria. At the center of this control system is the BCL2 family of proteins. These proteins act like guards that determine whether a cell lives or undergoes apoptosis. Some members of the BCL2 family protect the cell. These are called anti-apoptotic proteins. The most important examples are BCL2 and BCLXL. Their main job is to keep the mitochondrial membrane stable. They prevent the release of cytochrome C, often called CYTC. As long as cytochrome C stays inside the mitochondria, apoptosis is blocked. You can think of BCL2 proteins as bodyguards for the cell. They help cells survive during mild stress or temporary injury. This protection is important for normal tissue function and healing. But not all BCL2 family proteins are protective. Some are designed to trigger apoptosis when damage becomes severe. These are called pro-apoptotic proteins. The key players here are BAX and BAK. When activated, they create openings in the mitochondrial membrane. This allows cytochrome C to leak out into the cytoplasm. Once cytochrome C is released, the cell activates caspases. These are powerful enzymes that dismantle the cell from within. At that point, apoptosis moves forward rapidly. Another group of proteins acts like cellular stress sensors. These are the BH3-only proteins, including BAD and BIM. They constantly monitor the health of the cell. When the cell experiences DNA damage, oxidative stress, or lack of nutrients, these proteins become activated. They detect when the cell is no longer safe to preserve. BH3-only proteins help shut down the protective effects of BCL2 and BCLXL. At the same time, they activate BAX and BAK. This shifts the balance toward apoptosis. So, the fate of the cell depends on balance. If survival proteins dominate, the cell stays alive. If death-promoting proteins take over, apoptosis begins. This balance is extremely important in human disease. Too much apoptosis can contribute to neurodegenerative disorders. Too little apoptosis can allow damaged cells to survive and become cancerous. In many cancers, BCL2 proteins are overactive. They prevent abnormal cells from dying when they should. That is why some modern cancer drugs specifically target BCL2 pathways. The BCL2 family is like a molecular switchboard for life and death. It constantly evaluates stress, damage, and survival signals inside every cell. Intracellular accumulations happen when cells store abnormal amounts of substances inside their cytoplasm. These substances may include fats, proteins, pigments, or minerals. One of the most common examples is steatosis, also known as fatty change. Steatosis refers to the abnormal buildup of triglycerides inside cells. This problem occurs most commonly in the liver. That is why it is often called fatty liver disease. The liver normally processes and transports fats efficiently. It balances fat uptake, fat breakdown, and fat export. When this balance is disturbed, triglycerides begin to accumulate inside liver cells. At first, the fat droplets may be very small. Over time, they enlarge and fill the cytoplasm. The liver cells start looking swollen and pale. Several conditions can trigger steatosis. One major cause is chronic alcohol consumption. Alcohol damages liver metabolism and interferes with fat processing. Obesity is another major risk factor. Excess body fat increases the amount of fatty acids delivered to the liver. The liver becomes overloaded with fat. Diabetes mellitus can also contribute to fatty liver. Insulin resistance causes increased fat mobilization from adipose tissue. More fatty acids then enter the liver. Certain drugs and toxins may also damage liver cells. This can impair normal fat metabolism and worsen triglyceride accumulation. Some viral infections can produce similar effects as well. One important mechanism involves impaired export of lipoproteins. Normally, the liver packages triglycerides into lipoproteins for transport in the blood. If this export system fails, fat becomes trapped inside the liver cells. Another mechanism is excessive fat intake or increased fatty acid delivery. When more fat enters the liver than it can handle, accumulation begins. The liver simply cannot process the overload fast enough. In the early stages, steatosis may be reversible. If the underlying cause is removed, liver cells can recover. This is why lifestyle changes are extremely important. However, persistent fatty change can become dangerous. Chronic steatosis may trigger inflammation and liver cell injury. Over time, this can progress to fibrosis and cirrhosis. Many people with fatty liver disease may not notice symptoms at first. The condition is often silent in the early stages. Sometimes it is discovered during blood tests or imaging studies. Steatosis is a powerful example of how disrupted metabolism affects cell health. It shows how excess nutrients, toxins, and metabolic stress can overwhelm normal cellular function. When the balance inside the cell is disturbed, accumulation begins. Cells can accumulate different pigments and abnormal proteins over time. Some of these substances are harmless signs of aging. Others may indicate serious disease or cellular dysfunction. One important pigment is lipofuscin. Lipofuscin is often called the wear and tear pigment. It appears as yellow-brown granules inside cells. This pigment forms from the breakdown of damaged cell membranes and organelles. Over time, leftover cellular debris accumulates inside lysosomes. The body cannot easily remove these residual materials. Lipofuscin is especially common in aging cells. It is often found in the liver, heart, and nerve cells of older individuals. As cells age, oxidative stress gradually increases pigment accumulation. Although lipofuscin usually does not directly harm the cell, it is considered a marker of past free radical injury and aging. It basically reflects years of cellular wear and metabolic activity. Another very important pigment is melanin. Melanin is produced by specialized cells called melanocytes. These cells are mainly found in the skin, hair, and eyes. Melanin acts like the body's natural sunscreen. It absorbs harmful ultraviolet radiation from sunlight. This helps protect DNA from UV-induced damage. When skin is exposed to sunlight, melanocytes increase melanin production. That is why the skin becomes darker after sun exposure. This process is actually a protective response. However, melanin production can become abnormal in certain conditions. Too much melanin may cause hyperpigmentation. Too little melanin can increase sensitivity to UV damage. Cells can also accumulate abnormal proteins. This usually happens when proteins become misfolded or cannot be properly degraded. Misfolded proteins may clump together and damage tissues. One important example is amyloidosis. In amyloidosis, abnormal protein fibers called amyloid accumulate outside cells in tissues and organs. These deposits interfere with normal organ function. Amyloid can build up in the kidneys, heart, liver, and nerves. As the deposits increase, organs become stiff and less efficient. Serious organ failure may eventually develop. Another example is alpha-1 antitrypsin deficiency. This is a genetic disorder involving abnormal protein folding inside liver cells. The defective protein becomes trapped within the endoplasmic reticulum. Because the protein cannot be released properly, it accumulates inside hepatocytes. This can cause liver injury and inflammation over time. At the same time, the lungs lose protection against enzyme damage. Protein misfolding highlights the importance of proper protein quality control inside cells. When proteins lose their normal shape, they may stop functioning correctly or become toxic. So, pigments and protein accumulations tell an important story about cell health. They reveal how aging, environmental stress, and genetic defects can gradually alter normal cellular function. Dystrophic calcification is the abnormal deposition of calcium salts in damaged or dead tissues. It happens even when blood calcium levels are completely normal. This is one of the key features that separates it from other types of calcification. The process usually occurs in tissues that have already been injured. Dead or dying cells become a site for calcium crystal deposition. Over time, these calcium deposits can become large and visible. When cells are damaged, their membranes begin to break down. This allows calcium to enter the injured tissue more easily. The damaged cells also release substances that encourage mineral deposition. Tiny calcium crystals start forming inside the dead tissue. As more minerals accumulate, the deposits gradually harden. The tissue may eventually feel gritty or stone-like. Dystrophic calcification is often considered a sign of previous injury or chronic tissue damage. The body is essentially depositing calcium in areas where normal tissue repair has failed. One common example is calcification of heart valves. Over time, damaged heart valves can become thick, stiff, and calcified. This makes it harder for the valves to open and close properly. Calcified aortic valves are especially common in older adults. The stiff valve restricts blood flow from the heart. This condition can eventually lead to heart failure symptoms. Another important example occurs in atherosclerosis. In atherosclerotic plaques, fats and inflammatory cells accumulate inside artery walls. As the plaques age and become damaged, calcium deposits begin to form. These calcified plaques make arteries more rigid and less flexible. Blood flow becomes more difficult through narrowed vessels. This increases the risk of heart attacks and strokes. Dystrophic calcification may also occur in areas of fat necrosis, old scars, dead parasites, or areas of tuberculosis infection. Basically, any chronically damaged tissue can potentially calcify over time. Under the microscope, these calcium deposits appear dark blue and granular. Sometimes they form large clumps that are visible on X-rays or CT scans. Doctors often detect calcifications during imaging studies. Importantly, serum calcium levels remain normal in dystrophic calcification. The problem is not excess calcium in the blood. The problem is local tissue injury creating a favorable site for calcium deposition. This process shows how chronic damage can permanently change tissue structure. Once calcification develops, the affected tissue often loses flexibility and normal function. So, dystrophic calcification is more than just calcium buildup. It is a marker of past cellular injury and tissue degeneration. It reminds us that damaged tissues can undergo long-term structural changes even after the initial injury is over. Metastatic calcification is the abnormal deposition of calcium salts in otherwise normal, healthy tissues. Unlike dystrophic calcification, the tissues are not initially damaged. The main problem here is elevated calcium levels in the blood. This condition is strongly associated with hypercalcemia. Hypercalcemia means there is too much calcium circulating in the bloodstream. When calcium levels rise significantly, calcium salts may start depositing in tissues throughout the body. The body normally keeps calcium levels under tight control. Hormones, bones, kidneys, and the intestines all help maintain balance. When this balance fails, metastatic calcification can develop. One major cause is hyperparathyroidism. In this condition, the parathyroid glands produce excessive parathyroid hormone, or PTH. Parathyroid hormone increases calcium release from bones into the bloodstream. As blood calcium levels rise, the risk of tissue calcification increases. Bones gradually lose calcium while soft tissues begin accumulating it. This creates problems in multiple organs. Another important cause is bone destruction. Certain cancers, bone metastases, or diseases like multiple myeloma can rapidly break down bone tissue. Large amounts of calcium are then released into circulation. Vitamin D toxicity is another possible trigger. Excess vitamin D increases calcium absorption from the intestines. Too much calcium eventually overwhelms the body's normal control systems. Metastatic calcification often targets tissues that lose acid or have an alkaline internal environment. Some organs are especially vulnerable to calcium deposition. The kidneys are common targets. Calcium deposits may form inside renal tubules and kidney tissues. Over time, this can impair kidney function. The lungs may also become affected. Calcium can deposit within the alveolar walls and lung tissue. This may reduce lung elasticity and interfere with gas exchange. The gastric mucosa is another frequent site. Calcium deposits can accumulate in the stomach lining because acid secretion creates local chemical conditions favorable for calcification. Blood vessels, heart tissues, and systemic arteries may also be affected in severe cases. As calcification progresses, tissues become stiff and less functional. Organ performance gradually declines. Microscopically, calcium deposits appear as dark granular material within tissues. In advanced cases, imaging studies may reveal visible calcified areas. Doctors sometimes detect these changes during X-rays or CT scans. Unlike dystrophic calcification, metastatic calcification is a systemic problem. The underlying issue is excess calcium metabolism, not local tissue injury. That is why blood calcium levels are elevated. Treatment usually focuses on correcting the cause of hypercalcemia. Without treatment, calcium deposits may continue spreading throughout the body. This can lead to serious organ dysfunction over time. Metastatic calcification shows how delicate mineral balance really is inside the body. Even essential substances like calcium can become harmful when regulation is lost. Clinical biomarkers of injury are substances released into the blood when cells become damaged. These biomarkers help doctors identify which organ has been injured. They are extremely important in modern diagnosis and emergency medicine. Normally, enzymes and proteins remain safely contained inside cells. The plasma membrane acts like a protective barrier. It controls what enters and leaves the cell. But during severe cell injury, this membrane becomes damaged. If the injury progresses far enough, the membrane may rupture completely. Once that happens, intracellular contents begin leaking into the bloodstream. These leaked substances can then be measured using blood tests. Doctors use them as biochemical clues to detect tissue damage. Different organs release different enzymes and proteins. This allows organ-specific diagnosis. In other words, the biomarker often reveals where the injury occurred. It acts almost like a molecular fingerprint for damaged tissue. One of the most important examples involves the heart. During a myocardial infarction, or heart attack, cardiac muscle cells die from lack of oxygen. As the cells rupture, cardiac proteins enter the blood. Troponins are among the most sensitive cardiac biomarkers. Elevated troponin levels strongly suggest heart muscle injury. Doctors rely heavily on this test when evaluating chest pain. Another example is the liver. Damaged liver cells release enzymes such as AST and ALT into circulation. High levels may indicate hepatitis, toxic injury, or liver inflammation. The pancreas also has important biomarkers. In pancreatitis, injured pancreatic cells release amylase and lipase. These enzymes help confirm pancreatic inflammation. Skeletal muscle injury can raise creatine kinase levels. Severe muscle trauma or rhabdomyolysis may cause dramatic elevations. Doctors use these findings to assess muscle damage. Biomarkers are not only useful for diagnosis, they also help estimate the severity of injury. Rising levels may suggest ongoing tissue destruction. Serial measurements are often very important. Doctors may repeat tests over several hours or days. This helps monitor whether the condition is improving or worsening. Timing also matters. Some biomarkers rise quickly after injury and disappear rapidly. Others remain elevated for longer periods. For example, troponin may stay elevated for days after a heart attack. This gives doctors a wider window for detection. Different biomarkers provide different diagnostic advantages. Clinical biomarkers have transformed modern medicine. They allow early detection of injury before major symptoms appear. This often leads to faster treatment and better outcomes. However, biomarkers must always be interpreted carefully. Elevated levels do not always mean permanent organ damage. Doctors combine laboratory results with symptoms, imaging, and clinical findings. So, biomarkers are powerful diagnostic tools. They reveal hidden cellular injury occurring deep inside the body. By measuring leaked enzymes and proteins, doctors can track damage at the molecular level. Cardiovascular markers are substances released into the bloodstream when the heart muscle becomes damaged. These biomarkers help doctors quickly detect and confirm heart injury. They are especially important during a suspected heart attack. A heart attack, also called myocardial infarction, happens when blood flow to part of the heart is blocked. Without oxygen, cardiac muscle cells begin to die. As the cells become injured, their membranes break down. Once the membrane is damaged, intracellular proteins leak into the blood. Doctors can then measure these proteins using blood tests. This provides valuable information about heart muscle injury. The most important cardiovascular markers today are cardiac troponins. These include troponin I and troponin T. They are highly specific for myocardial injury. Troponins are proteins involved in heart muscle contraction. Under normal conditions, they remain inside cardiac muscle cells. Very little is found in the bloodstream of healthy individuals. When heart muscle cells die, troponins are released into circulation. Even small elevations can indicate cardiac injury. That is why troponin testing is extremely sensitive. Troponin levels usually begin rising a few hours after a heart attack. They may remain elevated for several days afterward. This gives doctors a useful window for diagnosis. High troponin levels strongly suggest damage to the myocardium. However, doctors still interpret the results together with symptoms and ECG findings. Blood tests alone are not enough for diagnosis. Another important cardiac marker is CK-MB. CK-MB stands for creatine kinase MB. It is an enzyme found mainly in heart muscle cells. When cardiac tissue is damaged, creatine kinase MB leaks into the blood. Before troponin testing became widespread, creatine kinase MB was one of the main tests for heart attacks. It is still useful in certain situations today. Creatine kinase MB rises earlier than troponin in some cases. It also returns to normal more quickly. Because of this, it may help detect recurrent heart attacks. Doctors often measure these markers repeatedly over time. This is called serial testing. Rising levels usually indicate ongoing heart muscle injury. These biomarkers have greatly improved emergency cardiac care. They help doctors diagnose myocardial infarction faster and more accurately. Early diagnosis allows faster treatment and better survival rates. Modern medicine depends heavily on cardiovascular biomarkers. They provide a molecular snapshot of what is happening inside the heart. Sometimes they detect injury before major damage becomes obvious. However, elevated cardiac markers do not always mean a classic heart attack. Severe infections, heart inflammation, or major stress on the heart can also raise troponin levels. That is why careful clinical evaluation is always important. Cardiovascular markers are powerful tools in modern medicine. They help transform invisible heart injury into measurable laboratory evidence. By detecting proteins released from dying heart cells, doctors can act quickly to save lives. Hepatic markers are blood tests used to detect liver cell injury. They help doctors evaluate the health of the liver and identify possible damage. Some of the most important hepatic markers are ALT and AST. The liver performs hundreds of vital functions every day. It helps process nutrients, detoxify harmful substances, and produce important proteins. Because of its heavy workload, the liver is vulnerable to many forms of injury. When liver cells become damaged, their membranes lose integrity. Intracellular enzymes then leak into the bloodstream. Doctors can measure these enzymes through laboratory testing. One of the most important liver enzymes is ALT. ALT stands for alanine aminotransferase. This enzyme is found mainly inside liver cells, also called hepatocytes. Because alanine aminotransferase is relatively specific to the liver, elevated levels often suggest liver injury. When hepatocytes are damaged, alanine aminotransferase escapes into the blood. The higher the damage, the higher the alanine aminotransferase level may rise. Another important enzyme is AST. AST stands for aspartate aminotransferase. Unlike alanine aminotransferase, aspartate aminotransferase is found in several tissues. Aspartate aminotransferase exists in the liver, heart, skeletal muscle, and other organs. That means elevated aspartate aminotransferase is not always caused by liver disease alone. Muscle injury can also increase aspartate aminotransferase levels. Doctors usually interpret alanine aminotransferase and aspartate aminotransferase together. The pattern of elevation often provides important diagnostic clues. Sometimes the ratio between aspartate aminotransferase and alanine aminotransferase helps identify the cause of liver injury. These enzymes commonly rise in hepatitis. Hepatitis means inflammation of the liver. It may be caused by viruses, alcohol, autoimmune disease, or toxins. Drug-induced liver injury, also called DILI, is another important cause. Certain medications can damage hepatocytes directly or trigger immune-related liver injury. As liver cells become injured, alanine aminotransferase and aspartate aminotransferase levels increase. Common drugs linked to DILI include acetaminophen overdose, some antibiotics, and certain anti-tuberculosis medications. Early detection is extremely important because severe liver damage can become life-threatening. Elevated liver enzymes do not always mean permanent liver failure. Mild increases may occur temporarily after infections, medications, or even strenuous exercise. That is why doctors consider symptoms and medical history alongside blood tests. In severe liver injury, enzyme levels may rise dramatically. Patients may develop jaundice, fatigue, nausea, or abdominal pain. Additional tests are often needed to determine the exact cause. Hepatic markers are essential tools in modern medicine. They help doctors detect liver injury early, sometimes before symptoms appear. This allows faster treatment and prevention of further damage. Alanine aminotransferase and aspartate aminotransferase provide important insight into liver health. They act like biochemical warning signals released from injured hepatocytes. By measuring these enzymes, doctors can monitor liver disease and guide patient care more effectively. Drug-induced cell injury happens when medications damage normal cells and tissues. Although drugs are designed to treat disease, some can also produce harmful side effects. The severity of injury may range from mild dysfunction to irreversible organ damage. Two organs especially vulnerable to drug toxicity are the kidneys and the liver. These organs constantly process, filter, and eliminate medications from the body. Because of this heavy exposure, they are frequent targets of toxic injury. Nephrotoxicity refers to drug-induced kidney damage. One common site of injury is the renal tubules. These tiny tubular structures help filter and reabsorb important substances from urine. Certain antibiotics called aminoglycosides can damage tubular cells. Examples include gentamicin and amikacin. These drugs may accumulate inside kidney cells and trigger cellular injury. Over time, the tubular cells may undergo necrosis. This condition is called acute tubular necrosis. The damaged kidneys become less effective at filtering waste products. NSAIDs can also contribute to nephrotoxicity. NSAIDs are non-steroidal anti-inflammatory drugs commonly used for pain and inflammation. Examples include ibuprofen and diclofenac. These drugs reduce prostaglandin production in the kidneys. Prostaglandins normally help maintain healthy blood flow to renal tissues. When blood flow decreases, kidney cells may suffer ischemic injury. The liver is another major target of drug toxicity. This is called hepatotoxicity. Many drugs become chemically modified inside liver cells during metabolism. Sometimes these metabolic reactions produce dangerous reactive metabolites. These unstable molecules can damage proteins, membranes, and DNA. The resulting oxidative stress may severely injure hepatocytes. Acetaminophen overdose is one of the most famous examples. In large amounts, acetaminophen generates a highly toxic metabolite called NAPQI. Normally, the liver neutralizes this compound using glutathione. But during overdose, glutathione stores become depleted. The toxic metabolite then attacks liver cells directly. Severe hepatic necrosis may rapidly develop. Isoniazid, a medication used to treat tuberculosis, can also cause hepatotoxicity. Some individuals produce toxic metabolites more easily than others. Genetics and liver enzyme activity influence susceptibility. Reactive oxygen species, also called ROS, play a major role in drug-induced injury. Reactive oxygen species are unstable molecules that damage lipids, proteins, and cellular DNA. Excessive reactive oxygen species production overwhelms normal antioxidant defenses. Mitochondrial damage is another important mechanism. Mitochondria produce energy needed for cell survival. When mitochondria fail, ATP levels fall and cells begin to die. Understanding these mechanisms is extremely important in medicine. Recognizing how drugs cause injury helps doctors prevent toxicity. Dose monitoring, hydration, and early detection can reduce risk significantly. Drug-induced cell injury reminds us that medications must be used carefully. Even beneficial drugs can become harmful under certain conditions. That is why safe prescribing and proper monitoring are essential in patient care. Cells are constantly exposed to stress throughout life. They face challenges from toxins, infections, lack of oxygen, and physical injury. To survive, cells activate adaptive responses that help maintain balance. These adaptations may include hypertrophy, atrophy, hyperplasia, or metabolic changes. As long as the stress remains manageable, the cell can usually recover. Adaptation is the cell's way of protecting itself. But adaptation has limits. When stress becomes too severe or prolonged, the cell can no longer cope. At that point, cellular injury begins. Some injuries are reversible. If the harmful stimulus is removed early, the cell may return to normal function. However, persistent damage can become irreversible. Several key mechanisms drive cell injury. One of the most important is ATP depletion. ATP is the main energy source for cellular activities. Without enough ATP, ion pumps begin to fail. Sodium and water accumulate inside the cell. The cell starts swelling and losing normal function. Calcium imbalance is another major problem. Normally, intracellular calcium levels are tightly controlled. During injury, calcium floods into the cytoplasm. Excess calcium activates destructive enzymes. These enzymes damage membranes, proteins, and DNA. The cell's internal structures begin to break down. Reactive oxygen species, or ROS, also play a central role. Reactive oxygen species are highly unstable molecules generated during stress and mitochondrial dysfunction. In excess amounts, they attack lipids, proteins, and genetic material. Oxidative stress can severely damage cellular membranes. Mitochondria become dysfunctional, and ATP production falls even further. This creates a dangerous cycle of worsening injury. If the damage becomes irreversible, the cell dies. Cell death occurs mainly through necrosis or apoptosis. These two processes are very different. Necrosis is uncontrolled and chaotic. The cell swells, ruptures, and releases its contents into surrounding tissues. This usually triggers inflammation and additional tissue damage. Apoptosis is much more organized. It is a programmed and controlled form of cell death. The cell shrinks, fragments, and is safely removed by macrophages. Unlike necrosis, apoptosis usually does not cause inflammation. It helps the body eliminate damaged or unnecessary cells cleanly. This process is essential for normal development and tissue balance. In clinical medicine, biomarkers help detect cellular injury early. Damaged cells release enzymes and proteins into the bloodstream. Doctors and pharmacists measure these markers using laboratory tests. Cardiac troponins help identify heart injury. ALT and AST help monitor liver damage. Other biomarkers assist in detecting kidney and muscle injury. Pharmacists play an important role in preventing drug-induced toxicity. They monitor medication safety, dosing, and laboratory results carefully. Early detection can prevent severe organ damage. Understanding cellular adaptation and injury is essential in pathology and pharmacology. It explains how diseases develop at the microscopic level. Most importantly, it helps healthcare professionals protect cells, tissues, and organ function. Let's quickly review some key concepts in cellular adaptation and injury. These questions help connect the major ideas we have discussed so far. Understanding these basics is essential in pathology and clinical medicine. First question: which cellular adaptation is characterized by a change in cell type? The answer is metaplasia. Metaplasia occurs when one mature cell type is replaced by another mature cell type better suited to handle stress. This is usually an adaptive and protective response. The body is essentially trying to survive a harmful environment. A classic example occurs in smokers. The normal respiratory epithelium may change into a tougher squamous epithelium because of chronic irritation from cigarette smoke. However, Persistent metaplasia can increase the risk of cancer development over time. Second question. Leakage of which mitochondrial protein triggers apoptosis? The answer is cytochrome C. Cytochrome C normally functions inside mitochondria during energy production. But during severe cellular stress, the mitochondrial membrane becomes permeable. Cytochrome C then escapes into the cytoplasm. Once released, cytochrome C helps form the apoptosis. This activates caspases, especially caspase 9 and caspase 3. The cell then undergoes programmed cell death, also called apoptosis. Third question. Necrosis in the brain is typically of which type? The answer is liquefactive necrosis. Liquefactive necrosis occurs when dead tissue becomes soft and liquefied. In the brain, enzymes released from dying cells digest the tissue rapidly. This creates a liquid-like mass within the damaged area. Brain infarctions commonly produce this type of necrosis. Unlike other tissues that become firm after injury, brain tissue tends to liquefy. This is one of the distinguishing features of cerebral necrosis. Fourth question. Name a cardiac-specific biomarker. The answer is cardiac troponins, especially troponin I and troponin T. These proteins are highly specific for heart muscle injury. When cardiac cells are damaged during a heart attack, troponins leak into the bloodstream. Doctors use blood tests to detect these elevated levels. Troponins are now among the most important tools for diagnosing myocardial infarction. Even small elevations can indicate cardiac injury. That is why rapid troponin testing is widely used in emergency medicine. These review questions summarize major concepts in pathology. They connect adaptation, cell injury, necrosis, apoptosis, and clinical biomarkers. Together, these concepts explain how cells respond to stress and disease. Understanding these mechanisms helps healthcare professionals recognize disease early and guide treatment decisions. At the microscopic level, every disease process begins with changes inside cells. That is why cellular pathology remains one of the foundations of medicine.